So we are live now.
Hello.
Hello, good morning everybody. This is Dr. Poonam Shah. I welcome you all to our MetaSearch 2021 OBECON. It feels very odd to not meet you all in person, but I hope you will all enjoy this first virtual conference that we are having. Over to you, sir.
So welcome everyone again. We have a very good lecture by a very eminent speaker, Dr. Shashank Joshi. Padma Shri Dr. Shashank Joshi is an icon for diabetes endocrinology in India, and we are privileged to have him here as an opening batsman. He has been former president of API, Endocrine Society, Research Society for Diabetes, ARROW, and so on. He was honored by the government of India by awarding him with Padma Shri in 2014. I don't think he needs any introduction. We are privileged to have him and have as our friend and a supporter. Dr. Shashank Joshi, please, and we have Dr. Suhas Erende, a senior diabetologist and physician, to moderate this session. Welcome, Dr. Erende. Dr. Shashank Joshi, please.
At the onset, thank you, Dr. Shashank Shah and your whole team from MetaSearch for making this digital event. I know that Pune is in and Mumbai are not shaping so well in COVID times, and we are in difficult times, and we have to talk of COVID. Unfortunately, we are in the second wave, whether it is Pune, Mumbai, or Maharashtra, and COVID and diabetes is a tsunami. So these are the twin pandemics which we are facing across the globe and planet Earth. And in India is no difference or no exception. So obviously, COVID is definitely going to impact diabetes, and that's something which we all know and we all recognize, and we all are seeing this patterns which are very categorical and clear cut. So what I want to do is how COVID impacts patients with diabetes. So that's the first part. We know that spread of COVID has reached pandemic proportions, and we are in the second wave now. And diabetes, obesity, and hypertension are the three prime comorbidities which are there. So is there really a link? So there is a lot of data to suggest that diabetes has higher incidence of infectious diseases. We also know diabetes has an increased form of risk from bacteremic form of pneumococcal infection, which is why we give the pneumococcal vaccine. It's an independent risk factor for developing lower respiratory tract infections. We all both know that type 1 diabetes and type 2 diabetes have a higher risk of serious infections. For example, 6% of infections related hospitalizations occur in diabetics, and 12% of infection related deaths are attributed to diabetes in a hospital scenario. So obviously, if you look at hospitalized patients with COVID from New York or from Mumbai or from Pune, 50% of them have hypertension and diabetes both, and with obesity. So what is the link? So the four links of diabetes in COVID is people with diabetes have issues related to innate immunity, and that's often linked to high glucose, both acute hyperglycemia and chronic hyperglycemia. We also know that diabetics have an exaggerated pro-inflammatory cytokine response. So they have increased IL-1, IL-6, and TNF-alpha. We also know diabetic patients have increased expression of ACE2 receptors. And the ACE2 is the target which the SARS-CoV-2 virus attacks, through which it swims into the lungs and the pneumocytes or the gut and the gut epithelial cells. And we also know diabetics are a pro-coagulable state, increased coagulation activity. And because of these four reasons, COVID and diabetes is a deadly combinations. As I told you, ACE is present in the lungs, heart, kidneys, enterocytes, and pancreas. And the SARS-CoV-2, here you can see in the receptors, it basically, the coronavirus is called corona because it has a spike protein. And the spike protein gives that crown-like, football-like appearance. And that spike protein docks into the ACE2 receptor. When it docks into the ACE2 receptor on any cell, whether it's the the pneumocyte on the lungs, the type 2 pneumocyte, whether it's a myocardial cells, whether it's a nephron, whether it's the enterocytes on the intestine, or whether it's the pancreatic beta cells, it triggers the TMP RSS2, which is the transmembrane serine protease. And that basically will open up the furin particles so that virus can enter and gets internalized into the system. And obviously we know that the ACE1 has a role between conversion of Ang1 to Ang2, while ACE2 is the one which makes that Ang2 less effective, and that's what is blocked by SARS-CoV-2. So obviously it is this ACE2 expression which is the key with diabetes, which is linked clearly in SARS-CoV-2. And what happens is when the SARS virus is being inhaled, first you get nose COVID, then you get throat COVID, then you get lung COVID. And when it is getting trapped, if our neutrophils are impaired, if our production of interferons by NK cells is poor, if our macrophage activity is poor, then there is increased ACE expression and the antigen is not presented properly, you get a dysregulated immune response in which the respiratory epithelium, which you can see on the top, gets necrosed. You get mucus production, capillary permeability, leaky capillaries, in which you not only get kidney and heart disease, but you get the lung storm, which is the typical called cytokine response syndrome or cytokine storm. So obviously, you know that diabetes clearly is now linked. And you can see in this illustration also that when the SARS-CoV-2 spike protein docks with the soluble ACE2 receptor or with the transmembrane ACE2, fundamentally the coronavirus destroys the islets of Langerhans through functional ACE2, and that makes the diabetes progress. So you also get a flat plus diabetes. Many people with SARS-CoV-2, first time they come with a decay-like situation. In fact, exactly a year back, today is the 19th of March, I saw my first case of a senior citizen, 91-year-old. He walked into the casualty of Lilavati Hospital with a glucose of 680. He was not a pre-diabetic. And when he was admitted to the ICU, he had a hyperosmolar state. And we did his SARS-CoV-2 and he was positive. And these were early days that time. And we saw that this patient recovered fully, needed insulin drip, but he was SARS-CoV-2. So this was probably a new onset diabetes we have seen because he had no previous history of diabetes. And remember, even with people with such high age, without previous pre-existing comorbidity, recover. So obviously, all data shows that when there is diabetes, the case fatality rate goes up, and we need to save people with diabetes. So obviously, here you can see glucose is a vital sign which predicts mortality in the hospital. If your glucose is high in the hospital with COVID, then there is a 28% higher risk of mortality, and without diabetes it is 6.2%. So clearly there's a fourfold increase in mortality with glucose. As I told you, there's a direct endocrine link. As I told you, the angiotensin 1 and 7 acts on the MAS receptor pathway that leads to an anti-inflammatory, anti-fibrotic response, which is favorable to recovery in people with COVID. And obviously, people with severe COVID and diabetes, there is an imbalance between these pathways of ATR1 and ATR2. And obviously, Ang1-7 is a peptide without biological activity. So the standard pathway which we follow in the renin-angiotensin system is ACE1 gets converted by ACE1 enzyme to angiotensin 2. That interacts with the receptor, causes vasoconstriction, inflammation, fibrosis, proliferation, causing hypertension, cardiac fibrosis, thrombosis, and ARDS. While this Ang2 is removed from the system by the enzyme, the cleaning enzyme called ACE2. Unfortunately, this ACE2 enzyme is eaten up by the SARS-CoV-2 virus. And that's why you will not get the reduction of ARDS, thrombosis, cardiac fibrosis, and hypertension. And that's the key in the pathophysiology and pathobiology of COVID, where diabetes, glucose, and the vasculature and the enzyme tree is linked with COVID. So as I told you, acute hyperglycemia is linked to mortality. We know diabetes is a very well-known risk factor for severe COVID. And what do we know now? So, this is meta-surge, but there is a term called meta-inflammation. So obviously, when there is high glucose or diabetes, it's an independent predictor of mortality and morbidity in people with COVID-19. It basically causes metabolic inflammation with predisposition to enhance release of cytokines. It's greatly elevated levels of inflammatory cytokines implicated in multi-organ failure. It has clearly impaired healing because of compromised immune system and inability of the body to tackle infection, impaired healing, prolonged recovery. And obviously, dysregulated immune response resulting in aggravated or prolonged lung pathology with a dysregulated immune response. Clearly, diabetes is a risk factor, and IDF now says that it's a functional immunocompromised state, and it is a a milieu or a culture medium to promote viral replication. So we developed an Indian COVID risk score a long time back last year in May, where age more than 55, male gender, hypertension, diabetes, obesity, chronic heart disease, COPD, asthma, chronic lung disease, chronic kidney disease and liver disease, any congenital acquired immunodeficient state, any corticosteroid immunosuppressant or transplant recipients, they all are having this. And we have all these hotspots and red zones in the country. And, we need to generate Indian antibodies and so on and so forth. We have our own Indian strains. And obviously, how do you manage priorities in people living with diabetes? Well, we need to continue, quality of care. We need to keep surveilling them, and we need to be very, very aggressive in care. So we need to tell them to have COVID appropriate behavior and monitor their glucose. That's the basic thing which we need to do. In outpatient care, we need to keep on telling them that glucose control is important. Continue and optimize your current therapy. Do not discontinue prematurely your established therapy because your glucose is normal, and set up a telemedicine or a connected health model. And obviously, there are practical recommendations. Try to keep your glucose under control, target in range, time in range, much better. And obviously, every minor illness with people living with diabetes can lead to deleterious consequences, including hyperosmolar state. So aggressive treatment is the key. Avoidance of hypoglycemia is equally important as a key. So obviously, people living with COVID and diabetes, if they are at home, you can still manage everything with their OHS. But if they get into the hospital, put them on insulin. That's a simple thing. And follow the simple sick day rules. So if you follow simple sick day rules, for example, look for dry thirst or mouth, passing of too much of urine, dehydration, tiredness, weight loss, then put them into a hospital. Or if they're vomiting, because they need to take insulin and fluids. So obviously, glycemic control is very, very crucial. And you need to do continuous monitoring with people with COVID, and obviously give them insulin. So obviously, when you get COVID and diabetes, just like any other illness, whether it's a flu, common cold, sore throat, UTI, bronchitis, chest infection, stomach infection, follow the steply simple sick day rules. Never stop insulin, monitor glucose every 4 hours, drink some calorie-free liquids, weigh yourself, check your temperature, and drink plenty of liquids if needed. Avoid all the sugary beverages and avoid hypoglycemia. So there are a lot of guidelines for hyperglycemic emergencies like DK and HSS. And all you need to do is take care of your diabetics. So obviously, if you get a type 2 diabetic who's asymptomatic, and 80% of people now in the second surge in India and Mumbai and Maharashtra are asymptomatic, then you can manage them with oral anti-diabetic medications. Some may need insulin therapy. So based on the age, severity of COVID, cardiovascular complications, hypoglycemia risk, you can actually do a patient-centered approach and manage their glucose and keep on ensuring that the glucose is managed well. Well, stop it usually the SGLT2 inhibitors. That's the standard of care. Metformin ideally should be stopped in the hospital situation. Sulfonylureas and insulin need some caution, and that's the way to go about it. In ordinary cases, subcutaneous insulins work. In severe cases, you will need IV insulin, and that's something which we can do. And try to keep optimal glycemic control. Check the glucose more frequently, and you can use all these agents. All these agents have an impact on the ACE2 enzyme. For example, insulin reduces the renal ADAM17 and in the diabetic mice, and reduces the urinary ACE2 shedding, increasing the intra-kidney ACE2 expression. But there's no human data to support it. Metformin sulfonylurea has no concern. In pioglitazone, there's upregulation of ACE2 in insulin-sensitive rats. So there's a theoretical risk of poor outcome. But in the human pulmonary ACE2 expression, there is no such data. In fact, it may be useful. Liraglutide, again, the same risk. ACE2 inhibitors are safe. SGLT2 inhibitors, on the other side, may have a theoretical risk of poor outcome because they promote the renal ACE2 activity. However, there's a trial which is ongoing on these agents. And of course, gliptins might be the only agents which may be protective. That's because you know that in the MERS, like SARS-CoV-1, the Middle East respiratory syndrome used like ACE2 the DPP as a receptor. So the only agents which have some role are the DPP4 inhibitors. Of course, COVID guidance on the front door, aggressive treatment. And then if there is severe illness, just give fluids and treat them like a DKA. All inpatients use insulin, and ICU use insulin, and follow simple protocols and monitor them aggressively. Simply, as I told you, stop all SGLT2 inhibitors. You can continue your ACE, ARBs, and NSAIDs if needed, and maintain glucose and ketones, and give good inpatient care. And don't forget to manage hypertension with ACE2 inhibitors, and highest standard of care can be given, and it has to be done. So DPP4 look as an attractive, lucrative option. And because you know that DPP4 are entry receptors along with ACE2, they are the key receptors for MERS SARS-CoV-2. They are serine protease receptors. Their structure is similar to SARS-CoV-2 viral serine protease, and they are anti-inflammatory, anti-fibrotic, and immunomodulatory properties. And they are increased in elderly diabetics and obesity. There's a lot of data which was published last year, retrospectively showing sitagliptin may have an impact, and also some mortality data to show that they can reduce mortality if you use DPP4 inhibitors. And there is a pathophysiological basis of using the gliptins like sitagliptin, which actually may be anti-COVID. And this is the pathophysiological graph which was published in Diabetes Care. So obviously API came out with its own recommendations for diabetes and obesity on COVID-19 as major risk factors. And clearly we need to be very aggressive in our cardiac care. Now, we are seeing the first wave is over. First wave had immediate mortality and morbidity. Then we had a tail of the first wave, which lasted. And now we are seeing the second wave, which is coming up. And then, of course, we'll have a third wave of interrupted care and chronic conditions. And the fourth wave, which will be of mental illness and psychic illness and burnout. So obviously, disasters and pandemic will have a unique challenge for healthcare delivery. And we recommend for COVID and diabetes, remote consultation and communication, and issues related to insulin titration, hypoglycemia, and hyperglycemia. So these are the things which we will need as standard of care. And clearly we need to categorize who will want face-to-face, who will want virtual consultation, and where we need to defend. Somebody is well controlled, you can just wait and watch and monitor. Virtual is what we are doing most of the time, but somebody with new onset type 1 diabetes, pregnancy with diabetes, people with diabetic foot or heart disease, they will need face-to-face consultation. So we need to protect our patients and preserve ourselves. That's the new normal and the new mantra. By detecting the presence of the virus and detecting antibodies against the virus, which is the molecular test and the serological test, I personally feel every diabetic should be having that. Test them aggressively, chase the virus out. And that's the way to go. And obviously, telemedicine has allowed us to do that in a better way. We know what is telemedicine. We all know how to use it. We know how to use it aggressively. And we know that telemedicine will have used so several apps. And, we need to ensure that. Don't forget nutrition. Adequate water is very crucial. ACE came out with a very nice guidelines on water intake, and ensure that we avoid soft drinks, coffee, juices, have enough vegetables, and, choose lean meat, fruits, choose complex carbohydrates, and control the amount of food. So canned goods need to be there. So we need to increase the focus on nutrition, mental health and stress, and consider vaccination. That's so crucial. And ensure that vaccine delivery is there. And don't forget other vaccines in diabetics. For example, their flu shot, their pneumococcal shot, their typhoid shot, their Hep B shot, their zoster vaccine, beyond their COVID vaccine. So that's equally important. So I think these are my last slides. Diabetes is a risk factor for SARS-CoV-2. And for more severe COVID-19 infection, it's clearly there. Tight glucose control is very crucial. Empowering doctors, patients, healthcare workers for managing diabetes to support patient care during the pandemic is very important. We need to use telemedicine and technology. So, I'm thanking Shashank and his team for allowing this meeting to happen through a tele mode, and Hardik and his team to do that. We need to, despite a protection on diabetics, we need to know which patients need hospitalization. And we need a very holistic approach for a type 2 diabetic patient. Thank you for a patient hearing. And I'll be happy to answer any questions if there are.
Thank you. Thank you so much, Dr. Shashank Joshi. Excellent speech and excellent summary as usual. I would request Dr. Erende to take over and maybe discuss, and if any questions, ask them.
An excellent presentation, Professor Shashank Joshi, as usual. And you had tried to jog our whole wits through your presentation. And we will probably be gasping if we really try to understand what we were detailing. One of my simple points is we need to really have a lot of coordination, a multidisciplinary team approach to the recommendations which you had just now looked at, because the patient will be probably handled more in the in-hospital stage, maybe in the ICU, maybe on insulin and multi-dose insulin or insulin infusions. But the discharge prescription and the follow-up usually will be done by the takes care of that patient. So would you advise something which is a more of a coordination, corroboration, and a teamwork in such situations?
Extra hours, hours, whatever. Any questions? Maybe I have one question, Dr. Joshi. Like how we had this legacy effect in UK PDS, which we have seen that 6 months of good control had long-term benefits on cardiovascular and other morbidity and mortality. Will there be a negative legacy effect of COVID-related treatment, maybe steroids, and maybe losing control of diabetes? Will it have a long-term impact on the patient's overall comorbidities?
Legacy effect is for good glycemic control in early diabetes. Whether good glycemic control will protect you from COVID, we don't know. But if you control glucose well in COVID times, your likelihood of getting, you will just behave like a normal person. So that comorbidity risk will go away. So that part I can say to a great extent that get your glucose under control, call your patients early, stay them under control and keep them under control. But keeping them under control actually mitigates the risk. So if you have their A1C 6.5 or 7, they are actually less likely to be at risk. There's a lot of literature actually that if they make you lose weight through a bariatric surgery, does the risk for COVID goes down? There was a lot of early research which was done, and probably it does because your risk comes down tremendously. But you need to understand that COVID treatment is all about timing and all about recognition who will deteriorate and who will not deteriorate. So if you rapidly pick up the patient early, treat him aggressively or her aggressively, and identify that this patient is not going to deteriorate. For that, you have simple predictors. Even if you take a CBC and take a red cell width, if it is not about 14.5 or neutrophil lymphocyte ratio or a CRP, that's good enough. You don't need all that LDH, ferritin every time, IL-6 every time. Your simple CBC, you can predict the patient, whether he'll progress or not progress. And diabetes, if he's there, it's better to play safe. But if your diabetes is well controlled, there's likelihood for legacy effect is more, Shashank, for complications. So it's more for long-term complications. Remember, COVID is an acute illness. So in acute illness, that legacy effect is not going to be long-lasting.
Any other questions, Dr. Erende?
Professor Shashank, I was just trying to ask you whether you really need a better multidisciplinary teamwork, because the patients will be handled in hospital by the intensivist most of the times. After discharge, the diabetes care will be handed over to the healthcare provider or the primary care physician. So would you really advise a better team care in such situations?
100%, Dr. Arande. I think it will be, we have seen deaths occurring between month 1 to month 3 because of poor glycemic control. And they go getting readmitted. And we have lost lives in COVID because of that. So I think I completely agree with you that we need to hand over these patients well. Often many of these patients take steroids, and steroids in the hospital has become standard of care. So their glucose goes haywire. They all have sugars of 400 and 500. When they come home, their diabetes is not well controlled. And many of them are continued with steroids, and their glucose is forgotten. And then they land up with severe deleterious complications. So I totally buy your point that there is need to be an integrated approach, as you said, and a multidisciplinary approach so that we all can work together as one team so that we can save our diabetic patients and their lives.
Quick advice from you, Shashank. This is a obesity conference. So when we utter diabetes, we most of the times don't utter obesity. And obesity COVID interface is a big issue, especially for invasive issues. So a quick advice and word about obesity aspect of diabetes and COVID interface from you.
Obesity is a big killer in the West with COVID. In India, the data has not been reproduced, which is why we were very disappointed when obesity was not included in the comorbidity also. Because, we didn't see deaths related to obesity with COVID. But that's probably because the obese patients are so sedentary that they never got out of their house. So they never got COVID. So that's a very different situation altogether. But you're very right that obese patients are more vulnerable for COVID. Obese, diabetic, hypertensives, if you have this deadly trio and you get COVID, your risk of death is very high if you don't take care of yourself. So that's very clearly. So obesity kills which wherever there is obesity, it kills. So it reduces lifespan, it has impact on mortality and morbidity both.
Any particular care needed after vaccination, or it will have no impact on?
Whether you get COVID, whether you have antibodies, or whether you take 1 dose, 2 doses, or vaccination, you still need to mask. Because I have seen cases with 2 doses of vaccine with antibodies with COVID. I have seen with antibodies COVID. I have seen third recurrence of COVID. I had a patient who had COVID in March last year, March end. Then he got COVID in October, and last week again he got COVID. So COVID is a predictably unpredictable disease. COVID doesn't have any protection, whether it is you have antibodies, whether you had past COVID, or whether you take vaccination. The only good thing is, whatever happens, you will be having less severe COVID if you are vaccinated or you have antibodies, and you're unlikely to die. So mostly you will be able to manage your second or third episode at home. Okay. So that is the only difference. Otherwise, you have no chutkara from COVID. You know why a lot of vaccinated people are seeing COVID surge is because they suddenly stop wearing their mask and doing what they want. Secondly, the antibody tests are more expensive than the vaccines. Most of these antibody tests are very poor on accuracy. So the total antibody of IgG, IgA, IgM is useless. Okay, that IgG total is also very useless. If at all you need to do an anti-spike and anti-RBD IgG antibody, which is almost 5,000-8,000 rupees, which I don't recommend you to do, everybody. And then see whether you have comfort protection or not. So it really doesn't matter. I think independent of your vaccination status, you should get vaccinated, everybody, because you will at least save your life. Because we don't know efficacy of vaccines. We don't know how long the vaccine protection will last, whether it will be 9 months or 1.5 years. So there are all unknowns. COVID is a journey into the unknowns. It is like sitting into a boat which is rocky and being left into the uncharted sea where you have to navigate it yourself. So the only thing we can do is hold the sails properly, which is the mask, and ensure that you stay clean and stay distant. And if you cannot avoid a crowded situation, wear double mask, period. And this will continue throughout 2021. Whether you have, also remember, many of these vaccines may not be very impactful against the second strain or the third strain. So masking is the only way you can see. Masking is strain independent. So I think masking will be there, and you as surgeons are more attuned to masking. So double masking is possible, and it's not difficult at all. So I think COVID is going to stay. I think we have to be very clear about it. I mean, Pune is in trouble, Mumbai is in equal trouble, and we are all into that. We need to do much more testing, aggressive tracing. We still need to get our acts together on COVID.
One more question which all patients ask us. Patient with morbid obesity and diabetes who is at home and starts developing symptoms like COVID. The question is, what should I do? Patient is morbidly obese at home, has diabetes and developing symptoms.
I would go and get admitted, Dr. Shashank Shah.
So
I would seriously tell you they should get admitted because they need better care and they can make mistakes. They are slow and sluggish. And I don't think diabetic obese patients or morbid obese patients should manage themselves at home. They should check into a hospital and allow somebody else to manage them. See, I'll tell you one thing. Home management can be very deleterious. And then it is too late. And what happens after 1 week, they feel COVID theek ho gaya. And it is the second week, which is the most fatal week, where they rapidly deteriorate. So I don't think you should do that. So if you have a comorbidity, better to get into hospital if they can afford it and they can have access to doctors like you.
okay, perfect. Another last.
Actually, this is a good time for them to schedule after their COVID is over, a good bariatric surgery later and get rid of their comorbidity for change, but maybe after 3 months, not immediately after COVID.
Okay, as you are an expert, one more doubt which everyone has, which I wanted to ask you. What should be the gap between the first and second dose of a vaccine? And there have been controversies to take it at 20 days or later.
There are no controversies. We have to go by science and guide by science. Currently, science is fractured. So, as far as Covaxin is concerned, the gap between 2 doses is 21 to 28 days, ideally 28 days. So that matter is closed exactly after 28 days. As far as Covishield is concerned, globally, they feel single dose protection is 76%. If you do 2 doses in 28-day gap, the protection is 65%. If you delay the second dose, by 8 to 12 weeks, the protection could be 80%. So deferring the dose for 6 to 8 weeks may be prudent. The government authorities do not allow you to defer the dose beyond 6 weeks.
Right.
It may be prudent to defer the dose for 6 weeks and take the dose after 6 to 8 weeks or 12 weeks.
Yes. Dr. Arinde, any other question?
I believe we can engage Professor Shashank Doshi for more number of, you can say, hours. He has such a vast knowledge on both diabetes, obesity, and COVID. He's a prominent member of the COVID task force of the state of Maharashtra. So he can always provide us the data, which is really coming probably this morning. But for the decency and constant of times, and for convenience of the organizer, Dr. Shashank Shah, you yourself, I believe that we can probably conclude this session. An excellent, you can say, opening session by Professor Shashank Doshi. Over to you, Shashank. Thank you so much.
Thank you, sir.
Thank you. Thank you, Dr. Shashank Doshi. Very good beginning, and I think excellent discussion, and we learned a lot from your knowledge. We would move to the second speaker. Hardik, can we have Dr. Sharan Godbole slide? I think he's online. He's a very senior endocrinologist, a renowned diabetologist from Pune. He's a co-author full-time with Diabetes 7th edition, Madhumeha 6th edition, ex-editor of Journal of RSSDI, Dr. S.N. Cooper Award Oration Maharashtra Ophthalmological Society, Dr. Baliram Dubey Memorial Oration Annual Conference, I am in Nagpur, and I know him for many years, an expert, a very good speaker, so I would invite him. And we have a very senior physician to moderate this session, Dr. Ravindra Sethia, sir. Welcome both of you. I would request Dr. Sharan Godbole to start his presentation.
I must first of all thank Dr. Shashank Shah for allowing me here in this MetaSurge OBECON 2021 and for this opportunity to interact with you. Liraglutide is a molecule that is currently preferred in type 2 diabetes in several situations, but by and large, because of its exquisite benefits on weight, it is largely used in obese type 2 diabetes patients. Of course, the benefits of liraglutide far extend beyond the weight loss, and that is what I'm going to focus today in my talk. The reason why liraglutide seems to have so many benefits is because of the nature of the secretion of the GLP-1 molecule and the expression of its receptors in multiple organs. We know, of course, that GLP-1 is secreted by the L cells of the gut, but also importantly, it is secreted in the neurons in the hindbrain. And therefore, the major action of GLP-1 receptor agonists like liraglutide is, of course, to improve the satiety. But in addition to this, GLP-1 also seems to work like a neuromodulator or a neurotransmitter in certain discrete anatomical and functional areas of the brain. The receptors of GLP-1 are expressed widely, not just in the pancreas or the heart, but even in the brain, the lung, the vascular system, the kidneys, and the gastrointestinal tract. Now, there are about at least 8 pathophysiologic defects that have been clearly defined in type 2 diabetes. And of these 8 defects, the ominous octet, GLP-1 receptor agonists such as liraglutide seem to address at least 6 defects. Of course, they would increase the insulin secretion, which is impaired in type 2 diabetes, and reduce the glucagon secretion that's increased in type 2 diabetes, and correct the incretin defect that is seen. But in addition, there is also a reduction in the hepatic glucose production, improvement in the appetite regulation, improvement in the glucose uptake in the periphery. And that is how GLP-1 receptor agonists seem to address most of the pathophysiologic defects of type 2 diabetes, which is why it seems to be an ideal choice to reach glucoviscerometabolic endpoints. Liraglutide, of course, is a GLP-1 receptor analog. That is to say, the basic skeleton is the native human GLP-1, but the disadvantage of native GLP-1 is its rapid degradation by DPP-4 enzyme and the rapid metabolic clearance. So to overcome these two defects, there are two changes that have been made in the native GLP-1 molecule. You first attach a C16 fatty acid side chain, which is linked via a glutamoyl spacer to the lysine at position 26. And the second change is you replace the lysine with arginine at position 34, and that provides only one binding site for the C16 side chain. Because of these two changes to the native GLP-1, the liraglutide is suitable for clinical use as a once daily subcutaneous injection. Of course, the basic reason why we use liraglutide is its ability to lower HbA1c, and this has been in center, which was the CV outcome trial, and here you can see that there is a 0.4% difference in the two arms. Remember, CV outcome trials are not efficacy trials, they are non-inferiority trials for 3-point MACE. So you technically should not get a difference in the A1C, but in these trials, by and large, there is a sort of a small change in the A1C between the two arms. But more importantly, on the right, if you look at various randomized controlled trials, and this is not a head-to-head comparison, remember, but by and large, if you take any of the GLP-1 receptor agonists, starting with lixisenatide, this is exenatide, this is lixisenatide, this is liraglutide, which I'm speaking about, and then you have once a week exenatide, dulaglutide, albiglutide once a week, and once a week semaglutide. So by and large, there is a very robust HbA1c lowering to the tune of about minus 1.4% for liraglutide, which is by and large unmatched as far as the GLP-1 receptor agonists are concerned. So across trials, GLP-1 receptor agonists in general have proven high efficacy in glycemic control, with liraglutide almost being like a gold standard. However, GLP-1 receptor agonists, including liraglutide, also reduce the postprandial lipids, and there are three parameters which I'm trying to show over here. One is the change in the triglyceride levels, the change in the HDL-C levels, and the change in the LDL cholesterol levels. And again, you can see that except for lixisenatide, which doesn't seem to show any effect on the lipid levels, all other GLP-1 receptor agonists show some favorable effects on the lipid profile, and you can concentrate on liraglutide over here. There is a slight reduction in the triglyceride levels, which is of course maximally seen with once a week semaglutide, but this is an excellent rise in the HDL-C cholesterol levels with liraglutide, comparable only to dulaglutide and exenatide once a week. And finally, the lowering of the LDL cholesterol is also seen with liraglutide. So liraglutide seems to improve certain cardiac risk factors in the form of HbA1c, body weight, of course, which are not in the LEADER trial, which is the CV outcome trial for liraglutide. And then there are some small decreases in total cholesterol, LDL cholesterol, and the triglycerides, with a small increase in the HDL cholesterol as seen in the LEADER trial. So in addition to these indirect effects on the blood pressure, the weight, and the A1C, GLP-1 receptor agonists such as liraglutide seem to have certain direct effects for risk factor modification. Some of these direct effects include an improvement in the endothelial function, increase in the nitric oxide, decrease in the intracellular and the vascular adhesion molecules. There are some direct effects on vascular smooth muscle activation and proliferation of smooth muscles, decrease in the vascular inflammation in the form of decrease in the PI1 and the C-reactive proteins, as well as decrease in the lipid accumulation. So the cardiovascular benefits of GLP-1 receptor agonists like liraglutide is not simply because of the indirect effects, because those reductions are not sufficient to explain the large cardiovascular benefit that is actually seen in the various CV outcome trials. So remember that we have both direct as well as indirect effects. So like for example, in mice models, this is a mouse model where liraglutide has been shown to improve the infarct size compared to placebo. following left arterial ligation. And then in addition, there is also an improvement in the myocardial glucose uptake following a period of ischemia and then a reperfusion. So compared to the control, which you can see over here, GLP-1, native GLP-1 would improve the myocardial glucose uptake. I told you about reduction of systemic inflammation, and this was also seen in the LEAD program where there was a reduction in the C-reactive proteins. These are of course not head-to-head trials, but rather trials with other anti-diabetic drugs such as say rosiglitazone, which has also shown good CRP reduction, also some reduction with glimepiride, but not so with glargine, but also seen with other molecules like exenatide and sitagliptin. So liraglutide also has shown to reduce the C-reactive proteins. However, what finally matters is not just reduction in the various risk factors, but actually reduction in events and reduction in mortality. And you know that the landmark trial, cardiovascular outcome trial with liraglutide was the leader trial. And that of course compared liraglutide versus placebo, and the primary endpoint was the 3-point MACE. And there was a 13% significant risk reduction in this primary outcome of the 3-point MACE. But in addition, there was a 22% reduction in the cardiovascular death, a 12% reduction in the non-fatal MI, which was of course non-significant, and a non-significant 11% reduction in the risk of non-fatal stroke. So by and large, MACE and cardiovascular death are very significantly reduced in liraglutide. There were also some pre-specified secondary outcomes related to the kidneys in the LEADER trial, and this was the analysis from the LEADER trial where there was a composite of macroalbuminuria, doubling of serum creatinine, end-stage renal disease, and renal death. And this is a comparison of liraglutide with placebo in the LEADER trial, and there was a 22% relative risk reduction of the composite renal outcome with liraglutide compared to placebo. Now, this reduction of the composite is largely driven by the onset of new macroalbuminuria. So this is what you see. Liraglutide reduces albuminuria in type 2 diabetes. We know that albuminuria, of course, denotes endothelial dysfunction, but it's a marker of kidney damage and a risk for kidney disease progression. So if you look at the liraglutide versus the placebo, and at the end of the trial at 36 months, that's the 0.80 relative risk reduction as far as albuminuria is concerned, the change in the UACR over time. If I were to summarize the multiple mechanisms of GLP-1 receptor agonists to alter the course of the continuum of cardiovascular disease in type 2 diabetes, of course, I told you it reduces various cardiovascular risk factors like hypertension, dyslipidemia, obesity, not to speak of the HbA1c. But it also, liraglutide increases the glucose uptake by the heart, causes vasodilatation, improvement in the smooth muscle tone, reduction in the ischemic injury, reduction in infarct size, improved salvage index, improvement in the LV function, reduced cardiac remodeling, decrease in heart failure, reduction in inflammatory parameters, delayed apoptosis of the myocardial cells, improvement in the endothelial function, reduction in platelet aggregation and thrombosis, and reduction in atherosclerosis and improved plaque stability. So we were really searching for an ideal anti-diabetic drug, which of course should cause a robust A1C lowering and a fasting and a postprandial lowering. And of course, you have the benefit of weight reduction with liraglutide. But on top of that, the advantages, you get the glycemic lowering with minimal or no hypoglycemia. You get a whole lot of direct and indirect cardiovascular benefits with a tolerable side effect profile, which is why liraglutide is approved for a wide variety of patients. I think I'll stop my talk over here. If there are any questions, I'll be happy to answer them. Thank you for your time.
Thank you, sir.
Start.
Thank you, sir. I request Dr. Sethia to unmute himself and maybe discuss more. By the time Dr. Sethia joins, sir, I wanted to ask you, in this COVID times, if a patient is on liraglutide, and he starts getting symptoms of COVID, what would you recommend for that person or a clinician?
Well, the large number of COVID patients are asymptomatic. So one continues with the liraglutide. Again, even if the patient is hospitalized, if only the patient is on steroids, the sugars are likely to go haywire, in which case patient is likely to require multiple doses of insulin subcutaneously or a continuous insulin infusion, at which times if the patient is not eating well, we would like to stop the liraglutide for that point in time. But otherwise, in the vast majority of patients who are asymptomatic, who have mild symptoms, if their appetite is good and there's no nausea or vomiting, you can continue liraglutide.
Can we have Dr. Sethia online again? Dr. Sethia, can you hear us?
Unmute kara.
You hear me now?
Yes, sir. Any comments, questions from your side?
To Dr. This is presentation of the talk. And I think I just want to ask one question to Mr. Murmure. Does this once a week dulaglutide also have the similar effect in terms of cardiovascular benefits and renal benefits, so that it's the ease of administration once a week for the patient than taking daily injection? Can you hear?
Sir, we couldn't hear you. Can you just come closer to the mic and ask the question?
You from your side, I think.
Increase your device volume, sir, please. Increase your device volume.
Can you hear me now?
Yes,
Better.
better.
See, Suzanne, the really nice presentation. I've got one query about dulaglutide. Does the dulaglutide have a similar effect on cardiovascular benefit and renal benefits also? Because definitely patients will prefer once a week injection than over once a day.
Once a week or once a week. Unmute.
If I heard correctly, he was asking whether dulaglutide once a week has a similar effect like liraglutide. Yes, as far as cardiovascular benefits are concerned, dulaglutide has similar benefits just like liraglutide. But I must say that the weight loss benefit with liraglutide is superior compared to once a week dulaglutide, even in the head-to-head trials. As far as renal benefits are concerned, there's more evidence currently with liraglutide compared to dulaglutide, but cardiovascular benefits are equal for both the molecules.
Sir, any
oral-
space? Yes, yes, sir. Yes, sir.
Oral, what is going to come in the market in India? Any idea?
Unmute.
Oral semaglutide.
Oral semaglutide.
Okay. So oral semaglutide doesn't currently have the evidence for cardiovascular benefit. It has good evidence for weight loss. It has excellent evidence for HbA1c lowering, but it currently doesn't have evidence for cardiovascular benefit. The trial did not show benefit. The cardiovascular outcome trial, it showed non-inferiority. But there are other trials which are ongoing for oral semaglutide, which are addressing different aspects of cardiovascular benefit. But the CV outcome trial did not show benefit, unlike the leader trial, which showed actual benefit.
Thank you. Thank you.
Sir, any special care for patients with renal impairment? Any special care for patients with renal impairment while use of
No,
liraglutide?
liraglutide is allowed to be used even in patients with renal disease. But as I again mentioned, if patient has got poor appetite or nausea or vomiting, then irrespective of the EGFR, one would not like to continue with liraglutide. One stops it because of for reasons of appetite or nausea. But otherwise, it is safe to use it in compromised renal function.
Okay, thank you. If any question from audience, you can definitely ask. Sushant, any questions from other people? Any questions from other?
Hello, Dr. Gaikwad basically. Hello, whether liraglutide can be used in case of hepatic cirrhosis patient, liver cirrhosis patient?
No, one wouldn't use liraglutide in hepatic impairment. A cirrhotic patient, one would only rather use insulin. That's the safest drug to use in diabetes with cirrhosis.
Thank you.
So any other questions from so many panelists here? I keep it open to everyone. Just looking for any questions from any participants now. Thank you, sir. This is well covered. Importance of liraglutide. You have always been a support. Thank you so much, sir. Thank you. Sit here, sir. Have a good day and be safe.
Thanks.
Thank you. Hardik, we can move to the next presentation from Dr. Neeta Deshpande. Yes. So very senior diabetologist, bariatric physician, a researcher, has multiple publications in peer-reviewed journals and textbook. Excellent speaker. We have heard her many times. Past chairman for Karnataka RSSDI. She is a PI for several clinical trials, as I mentioned earlier. Received the RSSDI Fellowship Award. She is FRCP from Edinburgh, December 2016. Coordinator Consensus Group RSSDI ESI Clinical Practice Recommendation for Type 2 Diabetes 2020. A Master in Medical Reversal of Diabetes, Medical Management of Obesity, and hence we have given this interesting topic, limitations of medical reversal of diabetes mellitus. Why is it not widely adopted by most diabetologists? Dr. Neeta, please.
At the outset, I would like to thank Dr. Shashank Shah and the OBECON team for giving this opportunity to me to speak on a very different kind of topic. I've been used to speaking about the advantages of reversal of diabetes, medical reversal, but today I'm going to be talking about the limitations of this approach. And I think the one person who can speak about it is a person who's actually doing it. So if you're doing it, you know the limitations. So I'm going to talk about how it is done and the limitations and why it is not being widely adopted. So this will be the overview of my talk, where I speak about what actually is the definition of reversal, medical reversal, and the principles that are used for this medical reversal of diabetes, and the chances of success and what determines this kind of success, and then the limitations and conclusions. So definition of reversal, it is not uniform and there is no general consensus for it, but though the exact criteria are being debated, most people agree that when the A1C is under 6.5 for a good length of time, without the use of medication, that would qualify as reversal of diabetes. There are terms such as partial and complete. A complete reversal is not even pre-diabetic, so it should be below 5.7, and that's how we have various definitions of reversal. But suffice it to say that a general definition would mean that no diabetes and no medication, that would qualify as reversal. Now, to understand the limitations, we need to first know what the principles are and what the methods that are being used for medical reversal, and then only we can know what the limitations are. So the basic principle of medical reversal of diabetes is calorie restriction. So whatever be the modality, whatever be the composition, the caloric restriction is supposed to be the key point which will take a person towards reversal of diabetes. So I'm going to just quote two studies here because they are a little longer term, and they are studies that have been quoted very often, and they've been in talks and in the journals in a big way, and have shown good results. So all of us know about the Look Ahead study, which had an intensive lifestyle intervention as against standard care, in which this included caloric restriction and increased physical activity. And then, of course, we all know about the more recent direct trial, which had low-calorie meal replacement diet, which was around 825 to 853 calories for 3 to 5 months, followed by stepwise reintroduction and a long-term weight maintenance program. And Evidence suggests that this kind of an approach of low calorie diet is effective in reversing diabetes in the short term up to 2 years, and its effectiveness was predominantly demonstrated in those with shorter duration since diabetes diagnosis. There's not too much evidence for this kind of a medical reversal beyond 2 years, and there is a little bit, but not too much. But these two mainstream studies have shown us that up to 2 years, yes, you can have this kind of reversal. The other approach, other than calorie restriction, is carbohydrate restriction. It's very interesting to note the history of carbohydrate restriction in diabetes down the years. So you have way back in 1923, before the discovery of insulin, this paper, which tells us that low carbohydrate diets were the most frequently prescribed treatment for diabetes. Obviously, there was nothing else, so they were prescribing low carb. And then later on, a diet low in fat, which by default is high in carbohydrate, became the standard recommendation. I'm not going to go into the details whether this approach was right or wrong, but this is what happened. Low fat came into vogue, which necessarily meant high carb. And then with the development of exogenous insulin and later the low fat paradigm, rather than preventing elevations in glucose, the goal became maintenance of blood sugar by giving these medications and not paying that much attention to the carbohydrate. So which meant that we do not really prevent the glucose from rising. We allow it to rise, but bring it down with the help of medication. This is what happened over a period of time. But now what has happened? There is now a resurrection of that low carbohydrate era. We're coming back full circle. And this full circle says that low carb has recently been endorsed as an eating pattern by the ADA and the EASD. So now people accept, the guidelines also accept that low carb is back and it should be one of the approaches. So the Veterans Affairs Department of Defense, these guidelines also recommend carbohydrate restriction as low as 14% of energy intake in its most recent guidelines. So now somewhere there is a resurgence of the low carbohydrate diets that have been coming in. Now these are separate trials, 32 separate trials examining carbohydrate restriction as a treatment for type 2 diabetes. So you can see here that because there is a heterogeneity in the methodology and the definition of what exactly constitutes low carbohydrate, it's very difficult to interpret these studies, and hence the evidence is supposed to be limited. So we can't really say that type 2 diabetes is reversed by low carb diet because this evidence is so heterogeneous and the definition itself is so varied. But in a recent systematic review of low carbohydrate diets, it appears that the greatest improvements in glycemic control and greatest medication reduction, which we call reversal, have been associated with the lowest carbohydrate intake. So as I said, these are the two approaches. Low calorie is of course important, but low carbohydrate also is one of the approaches towards reversal of diabetes. What is the percentage of success and what are the factors that determine the success in these kind of medical reversal of diabetes diets? So if you look at the success rates, what you can see here are 2-3 important studies which I have put in, and you can see here that the direct trial is the one that has the best results. We all know that in the look ahead study, although it was intensive lifestyle modification, the caloric intakes were not as low as they were in the direct. Of course, they had more number of patients. So this is at 1 year and 2 years. As I said earlier, we have data up to 2 years for medical remission of or reversal of diabetes. And the direct study trials are quite impressive. You have 46% reduction at remission in 1 year, and at the 2 years, the remission rate was 36%. So it's quite impressive, and more needs to be done, and we need to see what this is going to be down the line, maybe 5 years later or 10 years later. Lower baseline A1C. Now I was going to tell you about what improves the chances of success in medical reversal of diabetes. So obviously a lower A1C at baseline, greater level of weight loss. The more weight you lose, the more chances of reversal. Shorter duration of type 2 diagnosis. This is uniform across all the studies. and lack of insulin use at baseline. So in fact, in the direct study, insulin users were not included in the study at all. And this predicted higher remission rate in the look ahead study. And diabetes remission, again, according to this study, was more likely shorter diabetes duration, lower A1C, and people taking fewer medications and no insulin. So these were the chances. This is the chance of success that you can get if you are trying to do medical reversal. What about the low calorie ketogenic diet versus the low calorie diet? What happens to the remission if you're using a low carb diet? Now, a low carb diet often veers towards ketogenic diets. So what are the remission rates when you use the low carbohydrate approach? The slide that I showed you previously was a low calorie approach. Now, this is the low carbohydrate approach. And these are the studies that we have. And you can see here that we had the duration of the study from 24 weeks right up to 2 years. So here again, the maximum duration that we have of evidence is for 2 years. The reversal rates are quite impressive in these kind of diets, even more than simply a low calorie diet. So you have 95% versus 62%. And this 62% is for low calorie, whereas 95% is for low carbohydrate. 55% versus 0 in one particular study, 78% in another, 54% in another. And in this particular study, you can see that the retention rate at the end of 2 years was 74%, which is quite impressive and quite contrary to the belief that these diets are difficult to adhere to. So this is 2-year data and the retention rate is also quite impressive. So these are the remission rates and chances of success with the low calorie approach, and this is with the low carbohydrate approach. Most studies that you can see above in this table have utilized ad libitum intake in the carbohydrate restricted arm. By ad libitum intake, I mean the calories are not looked at. So they're just given the ketogenic diet and the calories are not calculated, and perhaps because the calories are not restricted, the retention rate could be higher. And despite the fact that ad libitum intake was allowed, spontaneous caloric restriction occurred in these studies. Bone mineral density, which is supposed to be a huge problem in ketogenic diets, has been found to be unchanged despite significant weight loss after 2 years of a ketogenic diet intervention, and there is this evidence for it. So it appears that at least up until 2 years, ketogenic diets are safe, they cause good bit of remission, and this is the data that we have. The limitation is that we have data for only up to 2 years as of now. So now let's come to the limitations of this kind of an approach. In fact, both the approaches. So this is for a low calorie diet. So let us look at the limitations of a low calorie diet that is used for remission of diabetes. Extreme heterogeneity is there, and there is a questionable long-term adherence as evidenced by the number of studies that we have seen, and I have shown you some evidence here. And unfortunately, the weight loss is not maintained in the long term. So you do not maintain the weight loss, the diabetes comes back. So you can remain reversed in diabetes as long as you can maintain the weight loss that one has achieved. Secondly, a substantial level of caloric restriction is needed. 600 calories, 800 calories, this is not easy to achieve. And this much caloric restriction is required to get reversal of diabetes. So a standard diabetic diet does not cause that amount of weight loss, and hence a standard diabetes care does not cause reversal. So for reversal, you require huge weight loss, and for that, you require a substantial level of caloric restriction, which is a limitation. Then lifestyle intervention with this kind of severe energy restriction may have some deleterious effects on body composition and physiology, though I have shown you evidence to the contrary in one of the previous slides, but this has to be looked into. Then the micronutrient deficiencies, this is with any approach, be it bariatric surgery, be it medical reversal, micronutrient deficiencies are a concern, and you would have to keep monitoring and kind of supplementing these kind of things, and the patient has to watch out for these deficiencies. This slide which I'm showing you, This is the most important limitation of medical reversal of diabetes, and that is physiological and metabolic adaptation towards weight loss. So it pushes the body towards weight regain. So this adaptation of the body in response to caloric restriction may shift the energy balance and hormonal regulation of weight towards weight regain after weight loss. And this kind of adaptation is usually not seen after bariatric surgery, but it is seen after weight loss, which is done on a in a medical way. And this is going to be the biggest problem for us. As you can see in the Stampede trial of 150 patients, you have 3 arms: sleeve gastrectomy, bypass, and medical reversal. So these two are clubbed together actually in the 3 arms, that is LCD, that is low calorie diet, LC is low carbohydrate diet. As you can see over here, metabolic adaptation occurs. There is more weight loss obviously with bariatric surgery, but you can look at the difference between low calorie diet and low carbohydrate diet, and you can see that low carbohydrate diet fares better than simply a low calorie diet. So this is what adaptation is all about, and this is just one slide I'm showing you which tells us that the gut hormone changes persistently oppose caloric restriction weight loss. And as you can see, ghrelin gradually increases and the satiety hormones which are there, they gradually go on reducing. And this hormonal change occurs after caloric restriction. That means you've had weight loss and then your hormones all go in the opposite directions and take you towards weight regain. And this is one of the biggest limitations of medical reversal of diabetes. Now, the low carb diets which are there, the limitations of this. So what I showed you now was the limitations of the low calorie diets. This is the limitation of the low carb approach. Long term hard outcome data are lacking. We don't have outcomes and we have data only up to 2 years. Transient rise in uric acid, then blood urea nitrogen transient rise. So of course the kidney function is not affected, but these are some of the concerns that doctors may have, the patients may have, and this could be one of the limitations. Now coming to the most important part, why do diabetologists or doctors not adopt medical reversal of diabetes as much as it should be? One is there is disbelief and mistrust. They simply do not believe that this is possible and this may not be maintained long term, and hence they may not agree for it. Second most important thing is in diabetes guidelines, A1C is the goal. Good A1C is the goal. Reversal has not yet come in the guidelines as a goal for diabetes management. And if your treatment is guideline driven, reversal does not feature in it. That is one of the most important things. The other thing is standard care of diabetes does not lead to diabetes reversal. And standard of care is taught to us right from medical college. Hence, it is easier to follow. The guidelines are there, you follow the guidelines and you're done. But reversal of diabetes has not yet made its way into the proper guidelines, and hence doctors do not want to adopt it because, as I said, reversal is not a goal in any of the guidelines, and people who want to follow the guidelines may not want to adopt reversal of diabetes as an option of treatment for their patients. The other reasons for not adopting medical reversal of diabetes is lack of nutrition knowledge needed for it. One has to know a lot about the fats, the carbohydrates, the proteins, which is often left only to the nutritionist, and the treating physician or diabetes doctor may not have enough knowledge of nutrition that is required for reversal of diabetes. The other thing is immense effort is needed for counseling and follow-up. First of all, to make the patient understand what reversal is. Secondly, to tell him to take it up, go on such a low calorie diet, how it is going to help him. This kind of counseling requires a lot of time and effort, and the physician may not be willing to invest in that kind of effort. So that is one of the limitations. The third another limitation is the team effort. You actually need a separate team that takes care of patients undergoing a reversal program. You would need the obesity physician. You may even need a bariatric surgeon. You may, just to give that knowledge, you will need one or two nutritionists, you will need a coordinator, maybe a social worker, maybe a psychologist. So it's a big team effort, and it may not be possible for every doctor or diabetologist to build such a team to dispense this kind of a program. Then this kind of a program can be expensive. It can be really expensive, as seen in the direct trial. Liquid meals are given. So these kind of liquid ready-made meals can be expensive. Investigations that are needed at baseline and at follow-up, micronutrient deficiencies, those supplements, the charges of the doctor, the nutritionist, all of this can make a reversal program pretty expensive, and that's why it may not be adopted. Lastly, weight loss maintenance after that particular weight loss period, that may require pharmacotherapy. So as I said earlier, hormonal changes do not support maintenance of weight loss. They try to take the person back towards the old weight. And hence, at that point of time, pharmacotherapy may be needed to maintain that weight loss. So the doctor may not be willing to do that, the patient may not be willing to take it, and this can be one of the limitations of treatment or reversal of diabetes by medical therapy. So these are the different physiological problems and the physician problems in dispensing this kind of a reversal program. And that is the reason that many doctors and diabetologists may not be taking up the reversal program, although we do have evidence, at least in the short term, that this can be done. Unfortunately, with the burgeoning type 2 diabetes epidemic, not all patients who need it may reach a bariatric surgeon and may not be able to get bariatric surgery done for a variety of reasons. And hence, medical reversal of diabetes is an option in such situations and should be tried, and more evidence needs to be collected over a period of time. So to conclude, while both the low calorie diet and low carb dietary approaches are convincing for reversing diabetes in the short term, up to 2 years, long-term maintenance is still not proven. There is limited available data supporting long-term maintenance of weight loss itself. So we don't have enough data for reversal, and we know that weight loss itself may not be maintained, and its associated glycemic improvements in response to low calorie diet. Long-term adherence to a low-carb diet will likely remain an obstacle, though we do have data that there is good retention even at the end of 2 years. Though the current body of evidence supports and suggests that bariatric surgery is most effective with prolonged remission, concerns associated with surgical complications, treatment cost, and complete lifestyle modification after surgery, there's no escape from that. These remain challenges. So the final word is that the current standard of care may be suitable for some, but others would surely choose reversible if they understood there was a choice. This choice needs to be given, and that is why more and more people need to adopt this method. And the choice can only be offered if providers are not only aware that reversal is possible, but they must have the education needed to review these options in a patient-centric discussion. So limitations are there, but the limitations can be overcome only if there is sufficient knowledge, and then this option can be offered. Of course, we need longer term studies, we need evidence for long-term remission or reversal. So thank you very much.
Very well said and well summarized. I think you answered all the questions which were hidden in this presentation, and we agree 100% to everything. Maybe one quick question. While starting medical reversal of diabetes, have you ever thought of, or is there any evidence to add pharmacotherapy from the beginning and maintain it for a longer time? Would that increase the percentage of remission?
That's a very good question. And yes, I think it would increase the chances of remission. It would increase the chances of better weight loss. Unfortunately, cost constraints are too many. And as I said, the reversal program itself is expensive. And as of now, the only pharmacotherapy that we have in India is liraglutide. And liraglutide is also expensive. And that's why this option, though we have tried it in a few individuals, is not sustainable financially for a long time. And hence, we don't have studies, or at least I don't have my own data because of these cost constraints.
Thank you. We have Dr. Shilpa who has just joined. Any comments, questions to Dr. Neeta? I think she has covered everything. No scope of asking any questions. Very well summarized. And everyone would agree, and I believe that this modality should be used more and more such presentations will help clinicians and patients to use it more frequently.
Excuse me, Dr. Gaikwad, basically, I want to ask some questions to Dr. Neeta Deshpande.
Yes.
Yeah, when she mentioned about the low carbohydrate diet, the low means how much low it should be.
Well,
And
that is
the
what I
second
said. There
question-
is, there is a heterogeneity in that, but a ketogenic diet qualifies as less than 50 grams. It can go all the way down to 20 grams also. But if you don't want to do a ketogenic diet and just go down in carbohydrates, the usual carbohydrate intake across the country ranges anywhere between 120 to 170 grams per day. If you just bring it down to say 100 or even 80 grams, in fact, it was around 80 grams or 90 grams in the direct trial, which was not a low carb diet, but lower than what we Indians actually consume. So if you go down to 40% of calories or around below 100 grams of carbohydrates, you will still get a better effect than a high carb diet. You need not go all the way down to a ketogenic diet, which is less than 50 grams.
My second question is basically, this is the patients who are suffering from diabetes and the microvasculopathy like nephropathy, where there is basically recurrent attacks of hypoglycemia. Can this type of diet, basically low carb diet, can be tried?
Actually, we have not done it in severe nephropathy. Moderate to mild we have done, but we have not done it in severe
The
nephropathy.
diabetes without any complications, basically we can try for this.
Not necessarily. We have done it in cardiovascular disease. We have done it in neuropathy, retinopathy, but severe nephropathy, we have not tried it out. But mild to moderate, yes, because we are not giving very high protein. So it doesn't really matter.
Thank you. Thank you.
Thank you. Thank you so much, Dr. Neeta. You're always a risky speaker, extempore speaker, so we might invite you again, maybe with Dr. Arya Sharma.
Sure.
Thank you so much.
Thank you.
Hardik, Dr. Shilpa is already there. Can we have the next presentation? Yes. So Dr. Shilpa Joshi, Director of Mumbai Diet and Healthcare, practicing dietitian, diabetes education, researcher, and I would say a good speaker present in all diabetes conferences, Vice President of Indian Dietetic Association, Secretary Aero, Master Trainer for Diabetes Conversation Maps, Course Director for National Diabetes Education Program, has trained more than 3,000 diabetes educators and presented at various national and international meetings, including the ADA, IDF, and International Confederation of Dietitians. I would say a unique personality who's present everywhere in nutritionists, diabetologists, physicians, and we just heard about medical reversal of diet, and I would request Dr. Shilpa focus on benefits of plant-based diet. Dr. Shilpa, please. And we have Dr. Vilas Gaikwad, who has already joined, very senior physician, who is going to moderate this session.
Hello, everybody. At the outset, I would like to thank Dr. Shashank Shah and his team, specifically Dr. Radhika Shah, for having invited me here. And I'm going to be talking on benefits of plant-based diets. It's indeed a time when veganism or plant-based diet has become very, very popular. And I'm grateful to Dr. Shashank Shah to give me this topic. So what is the definition of plant-based diet? Because whenever we try to understand a concept, we begin right from definition. Pardon me. A healthy plant-based diet aims to maximize consumption of nutrient-dense plant food while minimizing processed food, oil, animal food, including dairy products and egg. So here I want all of you to note this, that healthy plant-based diet involves consumption of nutrient-dense plant food and minimizing consumption of processed foods. So whether it is packaged foods or processed foods otherwise, like consuming highly processed grains, etc., oils. So fat intake is low, and animal food, which includes dairy, eggs, but also more specifically in Indian context, I would like to point out that it would be ghee and ghee products that are included here. It encourages lot of vegetables, either in raw form or cooked form, fruits, beans, peas, lentils, soybeans, seeds, and nuts in smaller amount. And this diet is generally lower in fat. Leading proponents in the field have varying options as to what comprises the optimal plant-based diet. Ornish diet, which is very, very popular across the world. Ornish et al. Recommend allowing animal products such as egg whites and skim milk in small amounts for reversal of various metabolic disease. And we know now diabetes reversal has come into fashion, but Dr. Dean Ornish around 20 years back had proposed reversal of cardiovascular disease with plant-based diet, and this was his program. Reversal program in the Cleveland, Cleveland Clinic Wellness Institute recommends completely avoiding all animal-based products as well as soybean, nuts, and particularly if there is severe coronary artery disease is present. Okay, so what is the difference between plant-based diets and vegetarian diets? This is something very interesting, especially in Indian context. Often plant-based diets are used interchangeably with vegetarian or vegan diets. And this is very, very true in this country where vegetarianism is very popular. Remember, vegetarian diets cannot be exchanged for plant-based diet. Vegetarian or vegan diets are adopted for ethical or religious reasons and may or may not be healthy. So very, very prudent example would be sort of Indian diets, which are truly vegetarian in so many places where individuals are vegetarian for generations, but these diets are not healthy. We are seeing it with a surge of metabolic diseases across this country. Because these diets, though they are vegetarian in nature, they lack vegetables and fruits in large proportion, which is a key of plant-based diet. And second thing is that they are very high in processed foods. So whether it is processed grains, it is intake of oil, and it is very, very rich in saturated fat, which comes either from dairy or it comes from ghee, which is used very, very predominantly in vegetarian diet. Pardon me for my cough. A key distinction is that although most of the diets like vegetarian, vegan, lacto-ovo-vegetarian, lacto-vegetarian are defined by what is excluded, and plant-based diet is defined by what is included in it. And that's the main difference. Like you would say vegetarian diet means there is abstinence of meat. Okay, whether it is poultry, whether it is fish, any kind of meat is abstained from. Okay, vegan diet will abstain all animal products, whereas plant-based diet, it actually includes a lot of whole grains and other vegetables and fruits. So this is a beautiful cartoon where it is shown that what are benefits of diets which are essentially plant-based. So data is linked to better health outcomes in adults like heart disease, cancer, BMI, and cholesterol. And there are a huge number of changes in metabolome and altered gut microbiota. In children, there is limited data, especially on health and development. And of course, there is possible nutrient deficiencies which can come around from lack of vitamin A, vitamin D, lack of cholesterol, and essential fat like docosahexaenoic acid. But the data is extremely limited. Okay, so obesity, this is actually Obesity Awareness Month, and Dr. Shah has done this program because it's a Obesity Awareness Month. So let's begin our discussion with the base of all metabolic disease, that is obesity. Obesity and nutrition is related to chronic diseases. So we know obesity leads to chronic inflammation, which can lead to CVD, type 2 diabetes, and even dysbiosis, where there can be inflammatory bowel disease, colitis, and colon cancer. And now we have a lot of data to prove this. But now, when we are living in COVID times, we have seen that obesity and chronic inflammation actually worsens the results in COVID infection. So if somebody has obesity or any of these metabolic issues, then their results post-COVID are not as good as otherwise. Obesity. So epidemiological studies sorry, indicate that vegetarian diets are associated with lower BMI and lower prevalence of obesity in adults and in children. And again, here I would like to emphasize vegetarian diet here essentially means plant-based diets. It does not mean the kind of vegetarian diets that we have in India, which are very, very rich in fat, because in India we see that very, very strict vegetarians also have a very high prevalence of obesity and metabolic diseases. Meta-analysis of adult vegetarian diets estimated a reduced difference of about 7.6 kgs for men and 3.3 kgs for women, which resulted in 2-point lower BMI. Similarly, compared with non-vegetarians, vegetarian children are leaner and their BMI difference becomes greater during adolescence. Studies exploring the risk of overweight and food groups and dietary patterns indicate that plant-based diets seem to be a sensible approach to prevention of obesity in children. And I think with increased prevalence of obesity in children across India, it is very, very prudent to start including plant-based diet, which excludes consumption of confectionaries, which includes consumption of sweets and highly processed fried food. Plant-based diets are lower in energy density, high in complex carbohydrates, fiber, and water, which may increase satiety and resting energy expenditure. Plant-based dietary patterns should be encouraged for optimal health. Diabetes. Adventist Health Study found that vegetarians approximately have half the risk of developing diabetes as non-vegetarians. In 2009, a study involving more than 60,000 men and women found that prevalence of diabetes in individuals on a vegan diet were about 2.9% compared to 7.6% in non-vegetarians. So you're seeing there is a drastic drop when individuals become vegan or plant-based, especially when there is lesser consumption of confectionery, sweets, and fried food. A low-fat, plant-based diet with little or no meat may help to prevent and treat diabetes, possibly by improving insulin sensitivity and decreasing insulin resistance. Bernard et al. Reported in 2006 that the result of randomized clinical trial comparing a low-fat vegan diet with a diet based on American Diabetes Association guidelines. People on low-fat, and here the key word is low-fat, low-fat vegan diet reduced by their HbA1cs by 1.23 points compared to 0.38 points on people with American Diabetes Association diet. In addition, 43% of people on low-fat vegan diet were able to reduce their medication compared to 26% on those on American Diabetes Association diet. So you'll see that the difference is twofold. Twofold more people were able to reduce their medication when they went on plant-based diet. Plant-based diets and cardiovascular disease, and this is one area which is the most researched. A low-fat vegan vegetarian diet is only dietary pattern that has shown cessation or reversal of atherosclerotic plaques in clinical trial when combined with exercise and stress management. Vegetarian diets are associated with reduced risk of cardiovascular disease in general, including reduced risk for ischemic heart disease and cerebrovascular disease. In European perspective, investigation into cancer and a nutrition study, vegetarians had 32% lower risk of developing CVD as compared to non-vegetarians. Systematic review and meta-analysis of 8 prospective studies among Seventh-day Adventists. Vegetarian diets were associated with 40% reduced risk of CVD events and 29% reduction in cerebrovascular events as compared to non-vegetarian. A recent systematic review of meta-analysis of 86 cross-sectional and 10 cohort prospective studies reported that a protective effect of vegetarian diet against the incidence or mortality from ischemic heart disease. This observed risk reduction compared with non-vegetarian diet pattern was 25%. Also on metabolic syndrome, because metabolic syndrome is essentially a conglomeration of all these problems. There's a reduced risk of individual component of metabolic syndrome, except for HDL cholesterol, are associated with a lower waist circumference, lower concentration of triglycerides, lower load in LDL, blood sugars, and blood pressure. Now, plant-based diet and hypertension or blood pressure. Meta-analysis of about 7 randomized controlled trials and 32 observational studies found that vegetarian diets both decrease blood pressure, both systolic and diastolic, as compared to diets which are omnivores. Okay. In observational studies, vegetarian diets were associated with blood pressure readings that were on average 6.9 mmHg and 4.7 mmHg lower for both systolic and diastolic blood pressure respectively. Blood pressure reduction was independent of salt intake, overweight, and exercise level. A reduction in systolic blood pressure measured by 5 mmHg is estimated to result in 7% reduction in all-cause mortality, 9% reduction in mortality due to coronary artery disease, and 14% reduction in mortality due to stroke. So just improving blood pressure by plant-based diet will lead to a lot of decrease in mortality due to various metabolic disease. Meat-free diet has a huge impact on lipids, and it has shown to have reduction in total and LDL cholesterol, which corresponds with about 10% reduction in heart disease, according to a meta-analysis of randomized controlled trials which were published by American Heart Association. Vegetarian, especially vegan dietary patterns improve both fasting and PP lipids, blood lipids, compared with conventional therapeutic diets with similar effects, those seen with statin therapy. If combined with moderate physical exercise, cessation of smoking, stress management, reduction of lipids can be even higher. So what are the mechanisms which are responsible for benefits which are associated with plant-based diet? Several mechanisms are there. They are lower in calories if they are consumed in the right spirit. Increased intake of fiber, again, if they are consumed in right spirit, with less of processed grains. Intake of vegetable and fruit should be high. Reduced intake of saturated fat and cholesterol if these diets do not have ghee in them. Higher intake of PUFA and UFA, especially coming from nuts and oilseeds. Increased intake of antioxidants and micronutrients, especially if the diets are rich in vegetable and fruit. Higher intake of vegetable protein if it is consumed in form of dals, and higher intakes of plant sterols, which are coming from nuts, oilseeds, so on and so forth. What are the shortcomings? Certain nutrients may be less abundant in plant-based diets when compared with diets with animal products. Also, there is a considerable variation depending upon specific diet choices. What are the nutrients? Protein, fat, particularly saturated fat, zinc. Zinc is very important, especially in COVID times, vitamin D and vitamin B12. However, manifestation of these deficiencies are not more common in vegetarian population than in omnivorous populations. And such dietary recommendations require appropriate guidance from a dietitian to ensure appropriate choice of food, cooking methods, and supplementation strategy. American Academy of Nutrition and Dietetics states that appropriately planned vegetarian, including vegan diets are healthy, full, nutritionally adequate, and may provide health benefits for prevention and treatment of certain disease. Appropriately planned means it is important to keep main sources of macro and micronutrients in mind and make sure that diet supplies one's need of all of them. Okay. Now, this is something which I have put purposefully because in India, if you are on a vegetarian diet, the source of protein becomes beans and legumes, that is dals and pulses. And most of our patients really do not like to consume them. But beans and legumes, dals and pulses have a huge effect on health. They have an anti-obesity effect with decrease in body weight and waist circumference. They have anti-diabetic effect where it improves glycemic control, increases insulin sensitivity, and decreases HbA1c. It has cardioprotective effect with decrease in cholesterol, decrease in triglyceride, decrease in blood pressure, decreased heart rate, increased vasodilation, and decreased inflammation. And most of all, it improves the gut health, colon health. It increases the microbial diversity and microbial composition. It therefore increases short-chain fatty acids and decreases inflammation. So in conclusion, plant-based diets differ from vegetarian diets as they are lower in fat and high in fiber. And I think that is one thing that we need to encourage in Indian context. Plant-based diets have shown immense metabolic benefit. Well-planned plant-based diets can be sufficient in protein, unlike what is thought. So it's very important to include a lot of dals and pulses in our diet. The only plant-based diet, only nutrient that plant-based diet lacks is probably vitamin B12 and vitamin D3, and this would require supplementation. Thank you so much for a patient hearing.
Thank you, Dr. Shilpa. I would hand over to Dr. Vilas Gaikwad, sir. Sir, any questions, comments?
Yeah, that was a very nice lecture, basically. And the difference, basically, I want to ask one question: whether this plant-based diet can be called as a balanced diet? And the second question is basically, what is the difference between Mediterranean diet and the plant-based diet? Mediterranean diet is so told to be basically more heart-friendly.
Yeah.
So,
I'll take the second question first. What is the difference between plant-based diet and Mediterranean diet? So Mediterranean diet is primarily plant-based, but it is not completely plant-based. So Mediterranean diet does permit use of eggs and fish, even a little bit of meat. But it is, yes, like you rightly said, it is primarily plant-based, which emphasizes a lot on intake of vegetable, fruit, and whole grain. So that's the first thing. And therefore, Mediterranean diets are very, very heart-friendly. What was the second question? Can they be complete? Yeah, plant-based diets can be complete as long as they are, like I said, they should be eaten in the spirit of eating a right diet. So just because you're vegetarian, then you cannot make mithai in ghee and eat it. So that's not plant-based diet. If you actually eat it in the right proportion, you can meet the protein requirement. Only thing that you cannot meet is fat-soluble vitamins and vitamin B12. And that's something that you will require supplementation. That's because plant-based diet also do not permit dairy intake. That is why. If vegetarian diet actually permit dairy intake, and even those deficiencies then can be taken care of.
thank you, madam.
Very well summarized. Thank you, Dr. Shilpa. Thank you for joining us.
Thank you for invitation.
Thank you, Dr. Gaikwad, sir.
Thanks.
We can move to the next presentation. Hardik, can we have Dr. Sherville's slide? Yes. Welcome and thank you, Dr. Sherville. He's an endocrinologist from Kolhapur, very good speaker, researcher. He's worked in the Department of Endocrinology, PGI, Chandigarh, and KM Hospital, Mumbai. Observer program in endocrinology at Massachusetts General Hospital, Boston, USA. Fellowship training at Texas Diabetes Institute, San Antonio. Presently working at Excel Endocrine Center, Kolhapur. And we heard from a nutritionist, but we would like to listen to an endocrinologist. We talk about reversal of diabetes, weight loss, whatever. Is plant-based diet really enough? Dr. Sherville, please.
Yes.
That's right. Hardik.
Dr.
Hello everyone, I am Dr. Sharvil Gadve from Kolhapur. First, I would like to thank Dr. Shashank Shah and the entire team for organizing such a wonderful conference. Today, I'll be talking about a very interesting topic. Is plant-based diet enough or best? What does the literature say? Plant-based diet. What is a plant-based diet? Diet comprised of mostly plant foods. Does not mean vegetarian or vegan. Plant foods include fruits, vegetables, nuts and seeds, whole grains, beans and legumes, coffee, tea, dark chocolate, and so on. Why a plant-based diet? Studies have shown it can decrease risk of many chronic diseases, cancer, diabetes, heart disease, high blood pressure, cholesterol, and so on. How do you define a plant-based diet? Unfortunately, there is no single definition, multiple definitions. However, we need to standardize the definition of plant-based diet. Other terms associated with plant-based diets can be lacto-ovo-vegetarian. So what does that mean? So no flesh, but may have eggs, dairy. There's a concept of vegan, that is no flesh, no eggs, no dairy, no honey. Pesco diet means in which fish is allowed and seafood is allowed. And semi-pesco occasionally includes beef, pork, and poultry. So number of definitions, number of different terminologies. What are the health benefits of vegetarian diets? Now, the possible health benefits have been discussed in multiple aspects. But what does the literature say? What is the hard evidence? What do randomized trials tell us about the benefits of a plant-based diet? Let's try to look at this important topic. Now, this is one study published in Nutrition and Diabetes, a plant-based diet in overweight individuals in 16-week randomized clinical trial, metabolic benefits of plant protein. So the background of this particular study was that a plant-based diet is an effective strategy in treatment of obesity. This was a 16-week randomized clinical trial. Interestingly, in this study, number of results were discussed. So overweight participants, 75 participants participated in this particular study. There was a control group as well. DEXA was used, multiple other parameters were used. The insulin resistance, the insulin sensitivity was measured, body composition was analyzed. So this was a well done study. What were the results? So the mean weight of patients in this particular study was around 92 kg, and a plant-based diet over 16 weeks showed a reduction in weight of around 6.5 kg. Mean BMI was around 33 kg per meter square, and a reduction of around -2 was seen. Mean fat mass was around 40 kg in the participants, and a reduction of around 4 kg was seen. So the good thing is that beneficial results were seen. However, if we closely look at the data, we realize that this is a short study. This is a 16-week study. The results are good, but not as robust as one would expect from similar trials done with other interventions. For example, either a GLP-1 agonist therapy or the results after bariatric surgery. So compared to the intervention-based options what we have, a plant-based diet will have outcomes which are very modest, but the good thing is some weight reduction in BMI, fat mass is definitely seen. This is another meta-analysis, vegetarian diets and glycemic control in diabetes, a systematic review and meta-analysis by Dr. Yokoma and group. 477 studies were identified in this meta-analysis. 6 met the inclusion criteria. 255 subjects from these 6 studies. Mean age was 42.5 years. Consumption of vegetarian diets was associated with a reduction of HbA1c. However, how much reduction was seen? So in the 255 participants, mean age 42, their mean HbA1c was around 8%, and the reduction seen was roughly 0.39%. And there was no significant reduction in fasting blood glucose. The reduction in HbA1c was significant, but was in the tune of 0.39%. So yes, plant-based diet did help patients reduce HbA1c, but the reduction was very modest and no significant reduction seen in other parameters like the fasting blood glucose. So what is the right diet? Definitely a plant-based diet helps. However, on its own, plant-based diet has very modest results, but definitely it will complement the results which we see with other interventions like the SGLT2 inhibitors, the GLP-1 agonists, and more aggressive interventions, more robust interventions like bariatric surgery. This can supplement these interventions, but on its own, it has very modest results. Another systematic review and meta-analysis. It looked at the association between plant-based dietary patterns and the risk of type 2 diabetes. This was again a robust meta-analysis. Large number of patients were assessed and the findings were positive. A significant inverse association was observed between higher adherence to a plant-based dietary pattern and risk of type 2 diabetes. Relative risk of 0.077%. Confidence interval, you can see, does not cross unity. So the relative risk was significant. So there was a benefit with plant-based diet, especially when they are enriched with healthful plant-based foods. It may be beneficial for the primary prevention of type 2 diabetes. So yes, definitely there is a role in primary prevention of type 2 diabetes. We need to educate the masses to have a healthy lifestyle, healthy eating habits, and plant-based diets have a definite role in this particular aspect. Another good review, I would say, published in PLOS One, it looked at the cardiometabolic risk factors in vegans, a meta-analysis of observational studies. 40 studies with 12,000 plus vegans and 1,79,000 omnivores were included. A very robust study, large number of patients. From food frequency questionnaires in 28 studies, vegans compared to omnivores consumed less energy, minus 11%, which was good, and less saturated fat, almost 50% less saturated fat. So these were the benefits. However, if we look at the hard endpoints, compared to controls, vegans had a lower body mass index, but what was the reduction? It was minus 1.72 kg per meter square. So that is a good reduction, but not a very robust reduction. Reduction in waist circumference, minus 2.35 centimeters. Again, a very modest reduction, not a robust reduction. Fasting blood glucose also some trend in reduction, but not a very robust reduction. This is another important review which has covered a number of studies. This was published in the Journal of Geriatric Cardiology. This is a review of plant-based diet for overweight and obesity prevention and treatment. This particular review came out with a number of observations and also cited number of limitations in the literature and the published data we have for plant-based diets. So what this review says is that there is a need to study use of plant-based diet for weight loss with more diverse populations, including racial, ethnic minority groups, males, young adults, children, and older adults. So a lot of more studies are required before we come to any conclusion. To date, there have been no plant-based diet weight loss interventions solely among older adults. So that data is lacking. Most of the weight loss interventions conducted with senior adults using standard diet approaches have been of low to moderate quality. Moreover, plant-based diet weight loss trials that last beyond 18 months are needed. Till date, most studies have been short studies, and we require more studies with longer durations in order to examine long-term health benefits and diet sustainability. Another limitation of plant-based diet weight loss trials which have been done till date is that very few of them have reported the physical activity level of participants, which can be a very important confounding factor. For example, from the Bernard et al. Systematic review, only 3 studies addressed changes in physical activity, with 2 studies seeing an increase in physical activity during their interventions, and 1 reporting physical activity remained unchanged. So the studies that are available probably are not that well designed, and we need more studies with more robust designs to analyze the clinical outcomes in a better way. So this is how a plant-based food plate would look like. So it will have a lot of leafy green vegetables, high-fat whole foods such as nuts are allowed. It will have fruits, it will have legumes, it will have whole grains. So this is a healthy pattern. We should encourage patients to consider this as one of the options. However, the results are modest. We cannot depend solely on the results from a plant-based diet to improve obesity over a long time or to improve diabetes control over a long time. We need to take help of more robust interventions like drug therapies, including SGLT2 inhibitors, GLP-1 agonists, and important interventions like bariatric surgery wherever indicated. Are there any nutritional risks associated with vegetarian diets? Yes. Vitamin B12 deficiency is a very important risk factor. We should always keep this in mind whenever we see a patient following plant-based diet. Also, essential fatty acids, there can be development of deficiency, including that of DHA. So all this needs to be considered. Even the iron status of patients following plant-based diet can deteriorate and they can have iron deficiency, and we need to correct this. So the bottom line for those choosing plant-based diet is such diets do not provide adequate amounts of direct sources of vitamin B12 or long-chain essential fatty acids, including EPA and DHA. We should help patients recognize supplemental needs for B12, EPA, and DHA whenever they continue on a plant-based diet. We should be aware of the symptoms of B12 deficiency, the possible risks with B12 deficiency. And all this needs to be kept in mind whenever we see or advise or follow up a patient doing plant-based diet. So ladies and gentlemen, to conclude, we can say that plant-based dietary patterns, especially when they're enriched with healthful plant-based foods, may be beneficial for primary prevention of type 2 diabetes. Plant-based diet is associated with improvements in body composition and reductions in body weight and insulin resistance. However, there is no robust improvement in HbA1c, and it is not comparable to improvements seen with drugs like GLP-1 agonist and bariatric surgery. Consumption of plant-based diets helps in improving glycemic control. However, the robust improvement cannot be expected, and we need to consider using appropriate therapies, interventions in addition to plant-based diet. Such diets do not provide adequate amounts of dietary sources of vitamin B12 or long-chain essential fatty acids, and we should help patients recognize supplemental need for all these vitamins, including B12. Plant-based diet weight loss trials that last beyond 18 months, more long-term trials are needed in order to examine long-term health effects and diet sustainability. So I would like to end this talk. I again thank the organizers for organizing such a wonderful conference. Thank you.
Thank you, Dr. Sharvil. Very well covered. One question. So we hear sometimes from some people reversal of diabetes with some diet like plant-based diet. Can you give your opinion, even though you mentioned in the slide, but I wanted to elaborate more on this point. Reversal of diabetes.
So reversal of diabetes will depend on multiple factors. So the first most important would be the duration of diabetes, the background history of a particular patient. So we cannot generalize any particular diet or any particular intervention and associate it with reversal of diabetes. It has to be an individual approach. We should encourage weight loss. So whether by a diet-based approach or by an intervention-based approach, patients who lose 5 to 10% of their initial body weight and have a short duration of diabetes, they do experience reversal of diabetes. However, they need to sustain the weight loss. They need to sustain the dietary changes in order to be in remission, or else they very soon land up in relapse and we again see their sugars rising. So what matters is weight loss. So it would be through a diet-based approach, it would be through a medical intervention-based approach, or through a surgical intervention-based approach. But weight loss is one thing which can help reversal of diabetes in patients with short duration of diabetes. So, but we cannot associate with any one particular intervention.
Very well, sir. Thank you. Thank you so much, Dr. Sharvil, for participating.
Yes.
Thank you. Have a good day. We can move to the next presentation. Hardik, can we have Dr. Hemant Fatale's slide? We have Dr. Sanjay Raut, sir, a senior physician, to moderate this session, and Dr. Hemant Fatale, a very senior endocrinologist known to us for many years, who has been a faculty in National Obesity, National RSSDI, National Gynae Endocrine, OBECON, various state and regional conferences. He has been the organizing chairman for National Obesity Conference, AeroCon 2018 at Aurangabad, which was a great success. Faculty in Scope Certificate course by World Obesity Federation. He has trained more than 100 physicians and gynecologists in certificate course by PHFI. He has established unique childhood obesity center, and their work and published papers on child obesity are known worldwide. The member of ESI, RSSDI, Aero, API, and the topic is very interesting: future of COVID vaccine and limitations. And we would like to listen from an endocrinologist. Are these less effective in patients with obesity, and why is it so? Sir, please.
Dr. Sanjay.
Very good morning, friends. Many thanks to Dr. Shashank Shah and his team for inviting me for this knowledge sharing. Now it is important to know BM of yourself and your patient as well. Obesity is not only cause for non-communicable diseases, but also responsible for acquiring communicable diseases, and COVID-19 pandemic is best example of it. Globally, 10.5 crore population suffered from COVID-19. Nearly 6 crore recovered. USA leads in number of cases as well as death numbers. India stands second in number of cases and stands third in death numbers globally. Out of 1.08 crore, 1.05 crore recovered from COVID-19 in India. Till March 2021, 11.8 crore infected with COVID-19, more than 26 lakhs lost life. More than 3,000 health workers lost life worldwide. I suppose this data is incomplete. All the waves of COVID-19, people with age groups more than 50 has maximum hospitalization rates than less than 50. It is more profound when age crosses 65 years of age. Major point of entry in body are ear, nose and mouth, although spread is possible from other routes also. Nose and mouth, although spread is possible from other routes also. Rates of transmission is more in crowded, enclosed spaces and for longer duration. Similarly, death rates also very high in white non-Hispanic, very negligible in Pacific Islanders. Similarly, death rates also very high in white non-Hispanic, very negligible in Pacific Islanders. Primary symptoms are like any other URIs. Symptoms may appear between 2 to 14 days after exposure. Loss of smell or change of taste are different from other URIs. Primary symptoms are like any other URIs. Symptoms may appear between 2 to 14 days after exposure. Loss of smell or change of taste are different from other URIs. COVID-19 is less aggressive in females less than 50 years of age. It is more aggressive in male gender and those having age more than 65 years of age. There was an epidemic of SARS-CoV-1 in 2003. There was some learning from out of it. There is some recovery in interstitial lung damage and also in steroid-induced femoral neck necrosis. Almost every system is affected by COVID-19. COVID-19 induced diabetes also reported from our center and published in virtual conference of International Congress of Endocrinology 2021, US Indo 2021. Case fatality is highest in Mexico, 8.5. Mexico also has highest number of overweight, that is 73%, and morbidly obese population more than 34%. Case fatality is least with India, it is 1.48%. SARS-CoV-2 antibodies by age and disease severity, limited understanding of magnitude and duration of antibody response in persons with different diversity, genetic background, comorbidities, age, and infection history. Comorbidity status at hospital admission among COVID-19 positive patients in New York City data. More than one comorbidity is associated with higher hospitalization rate. Look, obesity has a higher chance of hospitalization than diabetes mellitus. Predictors of mortality among COVID-19 positive hospitalized patients in this data from UK. Age and sex are more determinants of mortality. As age advances more than 50 years, hazard ratio increases constantly. Then chronic end organ damage like heart, liver, kidney, and neurological damage. Hazard ratio for the chronic liver disease is 1.51, for dementia 1.40, for obesity 1.33, as against diabetes 1.06. Obesity and chronic liver disease is more dangerous than diabetes or other comorbidities per se. CDC Morbidity and Mortality Weekly, published on 8 March 2021. Nearly 1.5 lakh adult hospitalized for COVID-19 infection was analyzed. 50% were obese. Hospitalization risk and death rates were very high in obese as compared to the healthy BMI. The risk for ICU admission was particularly associated with severe obesity. Need for ICU admissions for BMI more than 40, there is 6% increase risk. Moment BMI crosses 45, the risk jump to 16%. Need for mechanical ventilation is 12% in overweight, and it jumped to 108% in morbidly obese when BMI crosses 45. Risk for hospitalization, 7 times greater in obese BMI between 30 to 35. The risk increases more than 33% in BMI more than 45%. This is as compared to healthy BMI between 18.5 and 25. There is a U-shaped BMI related morbidity and mortality holds true for COVID-19 infection also. People with BMI less than 18.5 had 20% greater chance of admission as versus people in healthy BMI. Risk of dying 8% higher in BMI between 30 to 35, 61% higher in BMI more than 45 as compared to the healthy BMI. Limitations of this study. Because the study was limited to people hospitalized with COVID-19, the findings may not be applicable to all adults with COVID-19. About 1/3 population did not have BMI data. Extremes of BMI are associated with higher rates of COVID-19 infection, hospitalization rate, ICU admission rate, mechanical ventilation rate, and death rate as well. Overweight and obesity were risk factors for the invasive mechanical ventilation. Obesity was a risk factor for hospitalization and death, particularly adults less than 65 years of age. So what are the implications for public health practice? These findings highlight clinical and public health implications for higher BMIs, including the need for intensive management of COVID-19 associated illness, continued vaccine prioritization, and masking and policies to support health behaviors. Why obesity has associated so many comorbidities in the course of COVID-19? It has been postulated that obesity is chronic, suboptimal, ongoing, progressive inflammation. Let's understand how does weight gain can cause the inflammation. Once increase in size of adipocyte occurs, it attracts M1 macrophages, which in turn attracts CD8 cells, B lymphocytes, mast cells, T helper cells. This leads to secretion of various cytokines like TNF alpha, interleukin 6, interleukin beta. This precipitate adipose tissue inflammation and insulin resistance sets in. Obesity is chronic low-grade inflammation. Obesity-related inflammation, called metapinflammation, is associated with reduced basal metabolic rate as against acute inflammation, which is associated with increased basic metabolic rate. It is also chronic and progressive. It does secrete a lot of cytokines, which is responsible for continuous inflammation. As we had described, this low-grade inflammation makes macrophages to secrete cytokines. These cytokines acts on adipose tissue to cause endocrine dysfunction, acts on muscles, pancreas, and liver to precipitate insulin resistance and dysglycemia. Let us understand how SARS-CoV-2 infection behaves in obese individuals. Adipocytes have high number of ACE2 receptors, hence more and more SARS-CoV-2 proliferate at large numbers, and these obese patients are reservoir of COVID-19 viruses. And in obese patients, it takes long time to improve in COVID-19 infection. Adipose tissue produces excess angiotensin, which in turn in the presence of COVID-19 produces excess angiotensin 2. And this excess angiotensin 2 is responsible for the vasoconstriction, inflammation, and fibrosis. COVID-19 thromboinflammation is a default immune system along with inflammation leads to a thromboinflammation. COVID-19 infection is nothing but an acute or chronic inflammation in obese patients. As we understand, obese population are the reservoir of the COVID-19 viruses. This excess of viruses, as we understand, the inflammation leads to hypercoagulability. It also makes an immune dysfunction. It can cause pulmonary, heart, kidney, and endothelial dysfunctions. And in the presence of cardiometabolic disorders like hypertension, obesity, diabetes, dyslipidemia, the prognosis becomes worse. Recently, there is so many news in media about obesity and COVID-19 vaccination efficacy. Let's understand obesity and vaccination. Responses to vaccination against influenza, hepatitis B, and rabies are also reduced in those with obesity compared with the lean individuals. Compared with vaccinated healthy weight adults, vaccinated obese adults have twice the risk of influenza or influenza-like illness despite equal serological response to vaccination. Regarding obesity and COVID-19 vaccination, and this preprint is made available on internet on 26 Feb 2021. This is of fiber vaccine data. It has received wide media coverage from 3rd to 10th of March. So goals of this study. The first goal of study was to analyze antibody titers 7 days after the second dose of BNT162b2 vaccine in a group of 248 healthy workers. The second goal was to analyze how the antibody titer changes in correlation with age, gender, and BMI. This is the first study to analyze COVID-19 vaccine in correlation with BMI, age, and sex. And out of the participants, 99.5% developed humoral immune response after the second dose. The humoral response was greater in normal and underweight population than in pre-obese and obese population. The association remained after adjustment with age. The antibody response was better in females than males. Humoral response was greater in age group less than 37 years of age than age group more than 37 and more than 56 age groups. Hypertension group was also shows less humoral response, but it wasn't statistically significant. The findings imply that female, lean, and young people have increased capacity to mount humoral immune responses to COVID vaccine compared to male, overweight, and older population. The limitation of this study: research was published as a preprint and has not been peer-reviewed and is yet to be scrutinized by the fellow scientists. Most make the point that there is only 26 people with obesity among 248 persons in this study. Why in obesity vaccine is less effective? So maybe in mechanical cause like vaccine needle length not sufficient to pierce muscles in morbidly obese population. Obesity is low grade inflammation, hence poor hemolytic response. Maybe need of third dose or large dose required. Needs further studies to answer all these. Message to us is we need to be more vigilant with our patients who are older, male and obese. Obesity more than 30, COVID-19 patients should be aggressively managed. Teach our patients about diet, exercise, appropriate control of all risk factors and comorbidities associated with increased hospitalization, intubation, mortality, including diabetes control as well. Why vaccine is important in obesity? Obesity and overweight is a major risk factor for morbidity and mortality in COVID-19 infection. Overweight and obesity is associated with low-grade inflammation can weaken the immune responses. World Obesity Federation pulled data from worldwide, and this data was published in the form of Atlas in March 2021, that is this month. The question was, many questions were answered. Is overweight and associated with the severity of COVID-19 and need for hospital treatment? His answer is yes. It also confirms the link between COVID-19 and overweight across the globe. This data also confirms overweight and COVID-19 mortality is age independent. The link between overweight and COVID-19 mortality is dependent on wealth of the country. Overweight and COVID-19 mortality rate is independent of percentage of reporting by many countries. COVID-19 morbidity and mortality is more in morbidly obese than obese and overweight as such. This worldwide data confirms countries with higher number of overweight population have higher COVID-19 infection and also a higher morbidity and mortality rate. Vaccine for COVID-19 population is very important, especially in the presence of obesity. Obesity is a major risk factor for morbidity and mortality in COVID-19 infections. It was a year journey of milestones from disease recognition to virus sequencing to vaccine development planning to actually delivering vaccine to healthcare workers. Design of vaccine made on 15th of Jan 2020. From 16 March on phase 1 trial began. From October 22, more than 74,000 participants enrolled in phase 3. In November, both Moderna and Pfizer vaccine declared effective in more than 90% of population. From December, let us understand the vaccination worldwide. Vaccine rate according to continent, the doses administered per 100 people. North America is leading 18, followed by Europe 11, South of America 4.7, Asia is 2.6. Worldwide pool data, doses administered per 100 people. It is based within United States, UK, UAE, and rest is still not at aggressive rate. India is world supplier of vaccine. As of 15 March 2021, the government of India has supplied more than 58 million made in India COVID vaccine doses to over 70 nations. Israel has highest percentage of vaccination, 104 doses per 100 people. UAE has 67 and USA 230. India is way below down, 2.1 doses per 100 people. India has provided vaccine to so many countries. We are the world supplier of vaccine. We have enough in stock. We have skilled and enough teams. It is free of cost. People should come forward and take vaccination. We should increase the rate of vaccination to curb the second wave of COVID-19. Remember, vaccination is only answer. If you look at all the pandemics in the past, second wave is most dangerous, and this can be really curtailed down by the vaccination. Let us come forward and increase the rate of vaccination in our country. If you look at our vaccine policy priority, not ours, even worldwide, the first was a healthcare workers and then considered age comorbidities. If comorbidities are concerning the heart, in organ damage, and the malignancies, why not obesity? In fact, obesity has the highest number of morbidity and mortality than any other comorbidities except age. So we must convey our message to the government, and obesity should be considered as a priority in vaccination. If COVID-19 vaccine is successful, can we relax? No. Vaccine is for everyone, including obese. It's time to take vaccine now. In spite of vaccination, do not forget to maintain social distance, wearing a mask, repeated hand washing, and if you are sick, stay at home. Friends, we have understood that obesity makes individual to become reservoir of COVID-19 virus. Being weighing more than normal is associated with increased morbidity, increased rate of ventilation, and mortality in COVID-19 infection. Shedding 10% of weight with proper nutrition, increasing physical activity, and exercise will definitely help us. By increasing vaccination, we can curtail the rate of wave 2 of COVID-19. In Israel, rapid vaccination has proved to reduce infection rate. Let us join our hands for increasing vaccination rate in India. Thank you very much.
Thank you, sir. You covered the question very well, and we have driven some new point. Before that, let me request Dr. Sanjay Raut sir for any comment, questions.
Sir, excellent presentation by Dr. Patel sir. I have 2-3 things that our government is not supplying regularly COVID vaccine. At present, though we are exporting to vaccine to many countries, but we are lacking in the position for supplying in India. And last two.
Sir, you are muted. You can ask again.
Hello, sir.
Yes, please.
But we are not regularly getting supply from the government authorities, and people are in panic position. So if Dr. Shashank Joshi is there, I may request to the government that our supply should be on priority rather than exporting to other countries.
Very true. Very true.
And second thing is that we are giving only after 45 years and 60 years, and with 45 with comorbid conditions. But why not to young people? There are so many young people who are roaming here and there, and they are spreading the infection. So that should be target. So why not to open the policy for all the people? So that is the second concern.
Very true, sir. We'll pass on this message to Dr. Shashank Joshi as well as IME.
Yeah. Yes, sir. Yes, sir.
Let me come to the point, Dr. Fatale sir. He has compiled all the data, all the evidence very well, and probably has driven a very good and new point whether those with morbid obesity who are vaccinated should receive a third vaccine. I think it is very interesting to study antibody titer of morbidly obese patients who receive 2 vaccines, and maybe we can add value by suggesting a third dose, maybe as rightly suggested by Dr. Fatale sir. Anyone who's listening to this has any suggestions can write to Dr. Fatale, write to us. I will personally talk to him and we will try and work more on it. Sir, please. Hello? Sir, we can't hear you. Your mic probably has to be started.
They're connected.
Sir, we can't hear you. Patale sir, we still can't hear you. You can take your time. Switch on the mic. Switch on the mic. Hardik, can you help Dr. Patale sir? Hardik?
Yes, sir.
Can you help Dr. Patale sir? We can't hear him.
Sir, at your screen, There is a mute unmute button. Sir, at there, there is a small arrow. Can you click on that?
Or maybe his headphones are disconnected.
Remove your earphones, sir. Remove your earphones from your device.
Yeah, remove that.
Sir, headphones to me kada that disconnect kara computer person.
Disconnect from your device. Move your headphones from your device.
No, Hardik.
No.
Sir, increase the volume of your device, please. सर आप अपने ईयरफोन्स निकाल दीजिए और अपने डिवाइस की वॉल्यूम इंक्रीज कीजिए.
Let him try. Let him try. He was. He is probably reconnecting from another device or from his mobile.
Okay, no problem.
Yes, I think he is connecting.
Can you hear me now?
Yes.
Yes, very well.
Yes.
Yes,
I have
sir.
a comment. The moment the BMI started rising, and when it becomes pre-obese condition, the metabolic changes started occurring. But the BMI crosses 30, it's really when the inflammation sets in, and the acquired infection rate, maybe corona pandemic or maybe an influenza also is rate very high. So it's two components of it, that is metabolic change which occur in a early stage, in a pre-obese stage, but in a acquiring infection, and there is morbidity and mortality is really so with when with BMI crosses 30 or even 35 plus. So we need to address morbid obesity aggressively than the obesity per se.
Okay.
That's the only comment. Thank you.
Very good presentation. Very good, very useful, I think, for everyone to know. Thank you so much, sir. And thank you, Dr. Raut, sir.
Yes, sir. Thank you.
Have a good day, sir. Thank you for joining and sorry for making you connect again. Thank you, sir. We can move to the next presentation. Hardik, you can start Dr. Uday Phadke's presentation. He is actually busy in an emergency, but we can run his presentation. He is a well-known endocrinologist and from BJ Medical College, one of the senior endocrinologists from Pune. He has multiple publications. He was one of the co-authors with me in the COSMED study, which won the Vivian Fonseca Scholar Award. And we have been working together for more than 20 years. He's just now busy in an ICU, but we will listen to him. Hardik, you can start the presentation.
By diabetes and obesity, how they are influencing the outcomes for the COVID-19 and to what extent. So this is going to be the basic theme of my talk. As such, obesity and diabetes are serious disorders. And obesity is widely recognized as a key risk factor for development of type 2 diabetes. And the excess adiposity actually contributes by various mechanisms for the development of type 2 diabetes, and this one of the mechanisms there is actually inflammatory cytokines which comes from the fat and the free fatty acids which impair insulin response signaling, and therefore by this mechanism obesity may be a unifying risk factor for severe COVID-19 infection along with of course diabetes. And as you can see here in this figure, that a number of the inflammatory markers, which includes, let me just show you the typical markers like TNF alpha, interleukin 6, the ceramides, all of these factors, the macrophage chemotactic factors, all of them are actually influenced in obesity, and all of these inflammatory markers are also important in the outcome for the COVID infection. If you look at the risk of COVID-19 infection and obesity, this is a meta-analysis of 75 different studies. A lot of them are case controlled studies, some of them are retrospective or prospective cohort studies, and then there are some observational cross-sectional studies as well. And these cover a total of more than 399,461 patients. So a huge number actually. And if you see across the board, if you look at the relationship of obesity and the risk of COVID infection, we see that the odds of individuals with obesity being tested COVID-19 positive were 46% higher than those who are not obese. So basically, obesity forms a very important comorbidity with the COVID-19 infection. Also, it's not just the infection which sets in, it's also the outcome which matters. And when there is obesity, the mortality also changes. And again, you can see a huge amount of data from the same meta-analysis of 75 studies that I just alluded to. The pooled data from 35 studies shows that patients with obesity were more likely to have unfavorable outcomes with a 48% increase in the death rate. So this is a huge amount. And this is why obesity per se becomes a very important risk factor for predicting the outcomes of COVID-19 infection. The same thing goes for hospitalization with COVID-19. You know that not all patients need to be hospitalized. Some are quarantined at home. But the point is that if there is obesity, what is the risk of hospitalization? What is the risk of being placed in an ICU? And the risk of requiring intermittent mandatory ventilation. And you will see here for all of them together, the odds for hospitalization are 113% higher. The odds for admission to ICU are 74% higher. So it's not just that obesity predisposes people to development of COVID infection, but it also increases the risk for being hospitalized and also increases the risk for getting into ICU. So this is very, very definitely elevated. And there are different mechanisms. And these are typically associated with three different things: the obesity-related inflammation, obesity-related hyperlipidemia, and obesity-related high sugars, that is hyperglycemia, all of which are typically present in obese individuals. And you will see here that in obese people, particularly those with hyperglycemia, there is an increased risk of the expression of the ACE2 receptor. You know that the ACE2 receptor is the primary site where the COVID virus attaches, and therefore the risk of primary airway infection completely goes up. And because of the release of inflammatory monocytes and the impaired AM metabolism, we see that there is no early immune containment, and the pulmonary inflammation also keeps on increasing. So it's a all told thing together. Obesity leading to hyperlipidemia and hyperglycemia, and there is often associated hypertension as well, all of which make a person more prone to primary airway infection, early immune containment abnormalities, and excessive pulmonary inflammation. The obesity risk in COVID-19, we know, as I said, that the adipose tissue is rich in ACE2 receptors. So higher number of adipocyte means that a greater viral load and prolonged viremia, because the virus attaches to the ACE2 receptor. Increased visceral adiposity, which is a very typical feature in Indians particularly, makes it very important that there is a great efflux of pro-inflammatory cytokines, because we know that the adipose tissue is not just an inert organ, it's an active endocrine organ, and it secretes these cytokines, which are nothing but inflammatory proteins. And also, obesity is associated with a procoagulant profile. So we also know that in COVID, a lot of thrombotic phenomena and complications are seen, and therefore the use of the anticoagulants like low molecular weight heparin, aspirin is all noticed in when we are treating COVID infections. So all of these factors, raised ACE2 receptors, pro-inflammatory cytokines, and the procoagulant profile basically makes people more prone to complications of the COVID-19. Also, now the vaccination process has started off in India with a great gusto, but we also have noticed that the vaccine efficacy has been known to be slightly reduced in people with obesity, and that could be because of a result of poor effector T cell and helper T cell function and an impaired memory T cell response to vaccine. So the vaccine efficacy also goes down in people with obesity. Now, these are the obesity-associated comorbid conditions which are potentially implicated in worsening prognosis in patients with COVID-19. So, on the endocrine aspect, we have insulin resistance and hyperinsulinemia. We have prediabetes and type 2 diabetes. We have dyslipidemia, including hypertriglyceridemia. We have chronic inflammatory reactions. We have cardiovascular problems associated with COVID, and we know that hypertension and the association of cardiovascular and cerebrovascular disease also makes important comorbidities along with COVID. There is an enhanced activity of the autonomic nervous system in both obesity and diabetes, which makes possible the systemic arterial hypertension, cerebrovascular disease, and chronic kidney disease. As I said, there are rheological abnormalities, so therefore there is hypercoagulability and a tendency to thromboembolic disease. And we also know that obese patients also have secondary chronic hypoxia. They may also have pulmonary arterial hypertension, and all of this together makes hypoxia in COVID, which is already going to occur because of the pulmonary infection and inflammation, more aggravated when the patient with COVID is admitted to hospitals. Now, does comorbidity really increase the risk of patients with COVID-19? Clearly, we have definitive factors coming into us. Hypertension certainly is one, no doubt about it, and it's being considered as one important factor. The odds ratio is 2.29. That means patients are at least 2.2 times more at risk for developing severe complications of COVID when they have hypertension. With diabetes, it's even more. That means 2.47 times than people who are non-diabetic. When there is COPD, which is often these are associated risk factors of obesity. So cardiovascular disease, COPD, you will see that the risk increases between 3.8 to 6 times the usual disease. And therefore, hypertension, diabetes, COPD, CVD, and cerebrovascular disease are major risk factors for patients with COVID. And we know that all of them can actually coexist with obesity. So the link factor between all of them is very, very definitive. What about diabetes per se? If you look at the in-hospital mortality of patients with diabetes versus no diabetes, in the United States and Asia, we particularly see in Asia that there is a greater risk of death among patients with diabetes, particularly in Asia, and the risk goes up by almost 2%. This risk is even greater than patients seen in the US. So diabetes per se is a very important risk factor, not just for developing COVID related problems, but also for mortality in admitted patients. And why is this so? Because in patients with diabetes, there is already a higher incidence of infection. Typically, there are more complications in any illness when a person is diabetic. We already know that immune function is compromised, the cytokine response is altered, there is a change in the mobilization of the macrophages and the WBCs, change in chemotaxis and their phagocytic ability, and of course, there is a marked increase in oxidative stress in diabetics. In COVID, over and above this, above what we saw in just patients with diabetes getting admitted with other infections, there is an overactivation of T cells, which leads to what is called a very high pro-inflammatory cytokines, what we call the cytokine storm. And this is the cytokine storm actually, which produces massive inflammation and therefore patients succumb. And also we know now that over and above the diabetes and its attendant pancreatic dysfunction, COVID itself can cause pancreatic damage by attachment of the virus to the ACE2 receptors, which are also expressed on the beta cells. So the beta cells also get damaged. And we are seeing now the diabetics who were relatively fairly controlled before they developed COVID now show a very marked increase in the hyperglycemia. And this is particularly more so relevant when the patients are already diabetic. And we are seeing patients getting admitted to hospital with HbA1cs of 14, 16, 17, very, very bad control. So diabetes with complications and poorer glycemic control makes the virus survive longer and makes it more virulent through these various mechanisms. COVID-19 in people with diabetes, as I said, the important problem is several fold. The beta cell damage that is occurring because of the SARS-CoV infection, cytokine storm, both of which worsens the metabolic control in diabetes and also sometimes causes new onset diabetes. We have seen that patients were hitherto not diabetic and after COVID they have developed the problems. Those who are already diabetic or their problem worsens with COVID infection, we see that all the problems of diabetes like hyperglycemia, diabetic ketoacidosis or hyperosmolar coma, coagulation abnormalities, inflammation, all the problems related to obesity, and of course the attendant complications of diabetes. That means increasing age, because diabetes is more common as age increases. Hypertension and cardiovascular disease and renal disease is more common with diabetics. So all of these factors together predict worse outcomes for people with diabetes. There are many reasons why glucose fluctuates in patients with diabetes and COVID. Number one, of course, is that the diet of an admitted patient is very much altered. There is no exercise. The use of glucocorticoids, which is now one of the main factors or the main treatments in COVID, leads to a sharp increase in glucose. Plus, of course, stress conditions like other associated infections, glucocorticoids, the stimulation of the RAS system and the autonomic nervous system, all of these are going to be a problem. The usual treatments that are going on, like the different oral anti-hyperglycemic drugs, are often interrupted, therefore results in glucose fluctuation. And of course, patients are highly stressed. They are in great fear, they are anxious, they are tense, and we know that mental stress also increases glucose fluctuation and hyperglycemia. So a number of things, COVID-19 can cause human body to produce many inflammatory cytokines and can lead to extreme stress in critical patients. So all of these factors, the pro-inflammatory cytokines, the glucocorticoids, disruption of their usual medications, the severe anxiety, change in the diet, all of this can cause worse outcomes in diabetes. Relationship between obesity and severe COVID-19 outcomes in patients with type 2 diabetes. And this is a study called the Coronado study, the coronavirus SARS-CoV-2 and diabetes outcomes. And amongst almost 2,000 patients with type 2 diabetes, whether they were normal weight or they were overweight or they were completely obese, you will see here that overweight and obese patients are associated with poor early prognosis in patients with type 2 diabetes. So when diabetes and obesity come together, the response to COVID is much worse as compared to those people who are non-obese and yet are diabetic. So obesity per se, through the mechanisms that I just outlined earlier, also produces very bad outcomes. Now, how can patients with diabetes reduce risk from COVID? So one important thing is that those people who are diabetics must monitor their blood glucose frequently, and if their sugars are not under control, they must contact their doctors as early as possible. Take influenza, pneumonia vaccines as offered, and also the new corona vaccine that is available must be taken. And people with coexisting heart kidney disease require special care to stabilize their cardiac or renal status. So this is the responsibility of a physician also, to quickly look at his diabetic patients and make sure that at least the metabolic parameters are in control, and therefore the risk of developing COVID infection and the risk of developing severe COVID infection and mortality can be somewhat mitigated. What about the use of or the effect of the anti-diabetic drug classes on the COVID morbidity, mortality? There are several drugs that we know, amongst which insulin is now become very, very important. We already know that insulin is the preferred treatment option for critically ill patients, but not only does it provide good control, particularly in patients treated with steroid, but it also downregulates the ACE2 receptors. Insulin, as we know, reduces inflammatory markers, it reduces the chance of decay, and therefore it actually improves outcomes. What about metformin? Now, metformin has been studied in COVID, and clearly we know that people who were on metformin earlier to getting admitted, the numbers of deaths were lower, and so were the interleukin 6 levels. The in-hospital mortality was reduced, and there are several different pathways because metformin also acts through what are called the mTOR pathways, the AKT, the PI3K pathways, which themselves are anti-inflammatory and therefore inhibited viral replication. What do we do to patients on metformin who get admitted to hospitals with COVID? So metformin is continued in mild to moderate COVID. Of course, in critically ill patients, of course, we avoid metformin, but in other patients, metformin is continued. There is some evidence coming about DPP4 inhibitors that they have a potential to reduce the COVID-19 infections. Again, so if they are on DPP4 inhibitors, that means gliptins, these are continued in mild to moderate COVID infections. For acutely ill patients, we do not know what to do, but through some mechanisms, they do protect the people from COVID-19 infection. There is, of course, some signal about GLP-1 receptor agonist, that means dulaglutide, liraglutide. We don't know, there is some controversy regarding the susceptibility of these patients to COVID-19. So those people who are on GLP receptor agonists, please suspend this treatment at least transiently and shift them on to insulin or some other drug. Also, we know that these people also have loss of appetite and nausea, and therefore, chance that these patients will be even worse affected when they are already quite ill is quite high. So, GLP-1 receptor agonists, stop them. What about SGLT2 receptors? It's important to note that SGLT2 receptors are not treatments of choice, particularly when patients are ill, when they have unstable hemodynamic status, they are dehydrated. So in these patients, you must stop clearly the SGLT2 inhibitors. I am saying all this because many of these patients now, of our patients, are on a multitude of these drugs, and it's important to recognize what they are taking and stopping them. And this is a report saying that euglycemic decay with COVID-19 infection in patients with type 2 diabetes is a clear entity. So be very careful. GLP-1 receptor agonists and SGLT2 inhibitors, which are otherwise very good drugs for cardiac patients, have to be stopped when COVID-19 infection develops. So to summarize, obesity is clearly a risk factor for not only higher severity, but also worse prognosis in patients with COVID-19. Obesity-induced adipose tissue inflammation and its effects on the immune system play a crucial role in the pathogenesis of COVID-19 infection. Obesity also results in metabolic dysfunction, which may lead to diabetes, And diabetes itself is associated with immune dysfunction and increased inflammatory responses. Diabetic patients themselves have severe immune dysfunction leading to complications, and diabetes is among the most common comorbidities observed in COVID-19 patients. So be very careful about treating obesity aggressively, be very alert in treating diabetes, and this is the only way in which we can provide less morbid outcomes to people with diabetes and obesity. Thank you very much.
Thank you, Dr. Phadke. I think he is with an intensive care unit with an emergency patient. Let me welcome Dr. Unnikrishnan, Dr. Milind Patwardhan sir. Happy to see all great faces, authorities in diabetes and endocrinology. Dr. Hardik, we can go to the next presentation by Dr. Patwardhan sir. He's already joined. Yes. So Dr. Patwardhan is one of the senior most endocrinologists from Maharashtra. He practices in Sangli, runs Diabetes Endocrine Research Center in Miraj and Sangli. He has multiple national and international publications to his credit, and he has written books on diabetes for patient education. We have heard him many times, an excellent speaker, and we are eager to listen to him now. I think we can start the presentation.
Hello, everyone. It is so nice to be here for OBECON 2021 amidst the pandemic of Corona. And I sincerely thank Shashank for giving me this opportunity to talk on this wonderful subject. Now, we all know that obesity is associated with so many metabolic abnormalities like insulin resistance, metabolic syndrome, type 2 diabetes, fatty liver or non-alcoholic fatty liver disease, hypogonadism, variety of cancers, and so many other things like sleep apnea, stress incontinence. But we don't know what is the common pathway by which obesity predisposes us to particular these conditions. Now, obesity is an emerging threat to our population. There is no doubt about it. Overweight and obesity are characterized by dysfunction or excessive accumulation of fat that may damage health. According to the latest data of WHO, between 75 to 60, that is 40 years span, the prevalence of obesity has almost tripled, and at least 2.8 million people have died each year because of either obesity or overweightedness. And this problem is no longer confined to only high income, high socio-economic group of people, but it is affecting low middle income countries as well. So obesity, as we just saw, triggers many diseases such as type 2 diabetes, hypertension, non-alcoholic fatty liver disease, hypogonadism, obstructive sleep apnea, asthma, stress urinary incontinence. Usually this is supposed to go through a pathophysiological changes or abnormalities or biochemical abnormalities before the manifestation of these diseases. And these comprise glucose uptake changes, that is compromise in glucose uptake, insulin and leptin resistance, low-grade inflammation, modified sympathetic activity accompanied by reduced noradrenergic innervation, and thermogenesis, changes in the gut microbiota. But today I will concentrate on low-grade inflammation and how it is responsible for all the other energy balance disorders. Now, this is a very good review article which I will suggest to all of you to go through: macrophages, inflammation, and insulin resistance, which appeared in Annual Reviews of Physiology in 2010. Is proposed in this as the final common pathway that as the weight of a person starts increasing because of adiposity, the fat cells go on increasing in number, and ultimately they are going to become more and more hypertrophied, because at a certain point the cell division is overcome and the cell size increment is beginning, so that the adipocytes become more and more large. And this is especially so in the visceral area and epicardial area. So these two sides of obesity are especially dangerous for the inflammation provoking obesity, you can say. Now what you see here is the all are these adipocytes and how they are going on increasing in size as well as number. And when the size increases certain amount, then it overruns its blood supply and there occurs a relative hypoxia, which causes death of many adipocytes. The dying adipocytes start releasing certain inflammatory markers. And these markers and adipokines and cytokines attract macrophages to invade the adipocyte structure. Here, the macrophages are seen to be surrounding the dying or dead adipocytes, and this particular structure, that is a dead adipocyte surrounded by a crown-like crowding of the macrophages, is called as crown-like structure or CLS, and used to quantify the adipocyte death from the biopsies of subcutaneous and visceral adipose tissue. So what happens? This is called as white adipose tissue or VAT. Now, an adipose tissue, when it starts becoming hyperplastic and hypertrophic, it outgrows its blood supply, leading to hypoxia, adipocyte stress, and apoptosis. This is paralleled by increased production of MCP1 and several other cytokines that are traditionally involved in wound healing. In addition to recruitment, MCP1 may also stimulate proliferation of macrophages within adipose tissue. Macrophages form the envelope around a dead or dying adipocyte in a configuration termed as crown-like structure or histologic biomarker of inflammation. And macrophages that form the CLS engage in phagocytosis of dead or dying adipocyte. They themselves become lipid-laden and are called as foam cells. The dead adipocytes detected as crown-like structure are prevalent in visceral fat depots. So more than 90% of the macrophages infiltrating the adipose tissue of obese humans and animals are found dead adipocytes, forming characteristic elements that are typically forming the crown-like structure. And therefore, quantification of this CLS yields a fairly accurate number of macrophages infiltrating the fat depots. The visceral depots are prevalent sites of adipocyte death and macrophage infiltration. And due to greater susceptibility to death of the adipocytes found at this particular anatomical site compared to those found in the subcutaneous depot. Now, this is what is the diagrammatic representation of what I told you just now. This is a lean person's adipocyte. They secrete the healthy adipokine called as adiponectin. While as the obesity increases, the adipocyte becomes larger in size, becomes hypoxic, starts dying, is infiltrated by the macrophages, and then it releases many pro-inflammatory cytokines like IL-6, TNF-alpha, leptin, resistance. On the other hand, the adiponectin production goes down. The positive linear correlation found between adipocyte size and the CLS in these depots suggests that increased adipocyte size is a factor triggering macrophage infiltration. This suggests that visceral adipocytes reach a critical size, triggering death before the subcutaneous adipocytes can do it. And the established concept, therefore, is that the larger the adipocyte, it correlates with the greater insulin resistance. At the same time, free fatty acids are released from the entrapped adipocytes, and they bind to the toll-like receptors which are present on the macrophage cell membranes. now leading to increased nuclear factor kappa beta dependent expression of pro-inflammatory genes. Lipolysis and release of free fatty acids are further stimulated by TNF-alpha. So in short, it is the dying adipocyte surrounded by the macrophages releasing many pro-inflammatory adipokines. Here again you can see that when there is calorie excess, if the calorie excess causes increase in the cell number, adipocyte number, then usually the adipocytes are of small size. They maintain adipogenesis, their volume is low, insulin sensitivity is good, and there is low inflammation. But if the adipocytes don't proliferate but go on only increasing in the size, then they become unhealthy adipocyte or unhealthy expansion with decreased adipogenicity. This is increased cell hypertrophy, decreased insulin sensitivity, and low-grade inflammation with macrophage infiltration. And this is related to ectopic lipid deposition, which is one of the main, you can say, pathophysiological factor in development of non-alcoholic fatty liver, development of insulin resistance through deposition of triglycerides in the myocytes, then type 2 diabetes and coronary vascular death. This is the same in pictorial fashion. As the adipocytes increase in the size, they outgrow their blood supply and therefore they become hypoxic. And so they invite the macrophages, and macrophages invade and start destroying the dying adipocytes. So it is the dying adipocytes where the macrophages, which are normally in M2 mode, are converted into M1. Now M1 is the killer macrophage and M2 is the healer macrophage. So when the wound is healing or when there is no much inflammation, the M2 macrophages predominate and they do not produce much pro-inflammatory cytokines. They produce anti-inflammatory cytokines. But when obesity supervenes, the macrophages are converted into M1 macrophages, which are going to kill the adipocytes and release the. Okay. Now we will discuss something about non-alcoholic fatty liver disease. Is it seen properly? Yes. Now, as obesity progresses, it results in high prevalence and severity of non-alcoholic fatty liver disease and even promotes or liver-specific mortality is more in these patients. Now, what actually happens is, starting with the accumulation of triglyceride in the lipid droplets of hepatocyte, which is a causative factor in development of steatosis. The steatosis progresses to steatohepatitis or NASH, and this induces cirrhosis, elevates the risk of developing hepatocellular fibrosis, and ultimately malignancies like hepatocellular carcinoma. Now you can see obesity associated with dying adipocytes with release of pro-inflammatory cytokines associated with insulin resistance, increase in the free fatty acid levels, adipokine dysregulation, that means decrease in the adiponectin and increase in the leptin, and inflammatory responses affects the liver in such a way that steatosis followed by cell stress, then inflammation, fibrosis, cirrhosis, and then predisposition to primary hepatocellular carcinomas. Obesity changes the composition of immune cells in adipose tissue. This in turn triggers inflammation of adipose tissue and death of adipocytes. And inflammation of adipocyte tissue, release of free fatty acids, and infiltration by M1 macrophages all lead to insulin resistance and further progression of fatty liver. So just concentrate on this and you will find that it is the pro-inflammatory cytokines which are responsible for this. We also know that apart from insulin resistance and fatty liver, there is increased predilection to certain cancers in obesity. Now, what happens is the tumor promoting effects of obesity occur at local level via adipocyte inflammation and associated alteration in microenvironment, as well as systemically via circulating metabolic and inflammatory mediators. So we need more precise measurements of obesity. We need more precise, you can say, biomarkers to indicate adipose inflammation. At present, we are using C-reactive protein and IL-6. Moreover, adipose inflammation is a reversible process and therefore represents a novel therapeutic target. Now, cancer and microenvironment. Now you can imagine that tumor cells are surrounded by a small environmental milieu, which is something like a wound and its milieu. The importance of tumor microenvironment in the development, growth, and progression of cancer is well recognized. Chronic inflammation is a classic and prevalent example of ongoing perturbation within microenvironment. Moreover, epidemiologic data have established association between chronic inflammation and development and progression of several cancers, including gastric, esophageal, colorectal, hepatic, pancreatic, bladder, and lung. So the tumor microenvironment closely resembles that of a wound, and the chronic tissue injury, such as adipose tissue inflammation, can stimulate the same wound healing mechanism and generate a pro-neoplastic environment. Now, the cytokines generated in the inflamed vat, such as IL-6, they activate androgen receptors and therefore promote cancer cells, especially prostate cancer cell survival and proliferation. So this is very important that apart from pro-inflammatory cytokines, there is also stimulation of androgen receptors by these adipokines. Similarly, there is an enzyme called as aromatase, which is stimulated, which converts the androgen to estrogen and therefore makes them prone to more estrogen-dependent malignancies. So several pro-inflammatory mediators associated with VAT, including TNF-alpha, COX-2 derived prostaglandin E2, can induce aromatase, a rate-limiting enzyme for estrogen biosynthesis. And leptin also is known to be an inducer of aromatase. So in short, pro-inflammatory adipokines and their effects on even the hormonal, you can say, axis promotes tumorigenesis. Now what happens is when individuals who are obese have elevated free fatty acids, that induces a endoplasmic reticulum stress, because you see endoplasmic reticulum is a key organelle involved in protein folding. And when the free fatty acid mediated reactive oxygen species oxidize these proteins, then they cannot be folded properly. So there is unfolded protein load on the endoplasmic reticulum, and therefore there is endoplasmic reticulum stress because of this. And the major transducers of the unfolded protein response are mainly RNA-like endoplasmic reticulum kinase, which activates transcription factor, and these are responsible for many metabolic gene activation. So insulin resistance gene is activated by endoplasmic reticulum stress. So this VAT or white adipose tissue inflammation is ubiquitous in the sense that it is not only in a tissue in which you are looking for abnormality, like breast tissue. When there is breast tissue biopsy showing crown-like structure indicating beginning of the VAT or inflammation, it also indicates that such inflammation foci are also present in visceral adipocytes, in epicardial adipocytes. So it is a indicative of a diffuse phenomena. It's a sentinel for inflammation in other regional as well as distant adipocyte depots. Now, in addition to systemic inflammation, VAT inflammation is associated with metabolic syndrome. Metabolic syndrome, as you all know, comprises a number of clinical disorders such as obesity, especially visceral obesity, insulin resistance, dyslipidemia, mainly hypertriglyceridemia, and decrease in HDL, and increase in the small, dense LDL oxidized molecules, and is associated with worse outcomes in patients with breast cancer. So breast VAT inflammation may constitute a local mechanism contributing to association between metabolic syndrome systemically and adverse breast tissue outcomes. The MESA study, that is multi-ethnic study of atherosclerosis, included 6 different ethnic populations. Total about 4,000 odd people were investigated. They were of Caucasian, African, Chinese, Taiwanese, Korean background. And they showed that the graded association between obesity, metabolic syndrome, NAFLD, and inflammation with calcium scoring. So in short, adipocyte is not an inert storage cell anymore. It has good adipokines as well as bad adipokines. A healthy adipocyte produces many good adipokines which maintain insulin sensitivity, keep lipids in adequate quantity, suppress angiogenesis, help body to maintain ideal body weight. But when increased adipocyte size follows excessive caloric intake, it is associated with hypoxia and cell death. And the cell death, which is followed by infiltration by the M1 macrophages, stimulates a variety of pro-inflammatory cytokines, which are responsible for metabolic effects of this particular inflammation, as well as tumorogenic effects. You can see that there are many inflammatory cytokines which prevent insulin from its binding to the insulin receptor, causing insulin resistance and therefore predisposing to metabolic syndrome as well as diabetes. So the lean adipose tissue, when it becomes obese, starts getting out of its blood supply, starts dying, gets macrophage infiltration. Then there is liberation of many adipokines and many cytokines which are pro-inflammatory, and there is decrease in good adipokines, that is adiponectin, and this is associated with increased glycogenolysis, increased gluconeogenesis, plasma glucose is increased, resulting in metabolic syndrome as well as diabetes. And in the muscles, because of accumulation of intramyocytic triglycerides, also there is resistance to action of insulin, causing decreased glucose uptake. So all these ultimately result in insulin resistance, hyperinsulinemia, and through so many pathways like endothelial dysfunction, endothelial activation, plaque formation, plaque rupture. Not only diabetes, metabolic syndrome, but coronary vascular disease is aggravated. Apart from this, there is increased incidence of heart failure with preserved ejection fraction in obese people. So although these patients exhibit an expansion of plasma volume that is proportional to their body mass, their primary pathophysiological abnormality appears to be a decrease in ventricular distensibility. The capacity of the left ventricle to dilate is in response to increase in the blood volume is impaired, and thus even modest degrees of volume overload can lead to cardiac overfilling and disproportionate increase in the cardiac filling pressure. Similarly, the epicardial fat is also susceptible to increase in the adipocyte infiltration by macrophages, and where systemic inflammation as well as focal or local inflammation is seen with release of pro-inflammatory cytokines. And therefore, it is noteworthy that in chronic inflammatory states, the accumulation of epicardial adipose tissue is closely associated with presence, severity, and progression of the coronary artery disease, especially in visceral obesity. The accumulation of epicardial fat closely associated with impaired myocardial microcirculation. Because here it is very important to understand pericardium, then epicardial fat, and myocardium. There is no barrier between myocardial cells and the epicardial or endothelial cells and the epicardial adipocytes. So they share similar nutrients, similar cytokines, and therefore patients with obesity related high heart failure with preserved ejection fraction have increased epicardial fat thickness, and they exhibit a shift towards synthesis of pro-inflammatory cytokines. You all know that COVID-19 infection is also more common in obese people. Obese people are 113% more likely to get hospitalized if they become affected, 74% more likely to be in the ICU, and 48% more mortality is reported in obese. This is now well known. The cytokine storm also is likely to be more severe, recovery slow, late COVID syndrome is more open, and all this is related to underlying inflammation. So coming to the end of my lecture, what is the take-home message I would like to give? That with increasing visceral adiposity, there is progressive and graded increase in the local, focal, and systemic inflammation. It is mediated via adipocyte death due to hypoxia, activation of M1 macrophages, release of pro-inflammatory cytokines. It can be measured by CRP and IL-6 levels. This is correlated with insulin and leptin resistance, metabolic syndrome, type 2 diabetes, atherosclerosis, non-alcoholic fatty liver disease, and predisposition to many cancers. But the process is reversible and it lends itself to pharmacological modulations. So this is going to be a hot topic in future, so we can prevent many metabolic and cancerous complications of obesity. Thank you very much. Thank you, Shashank, and thank you everybody for listening to this. Thank you.
Thank you. Thank you, sir. Thank you, sir. Very well covered, extensively covered.
Shashank.
And- Yes, sir.
I appreciate the way you have organized the conference, and this was a good, sort of, you can say, but some host is not allowing me to speak or show my face here. So just, am I audible?
Yes, sir. Yes, sir. I can hear you.
So if there are any questions, I will answer them.
Yes, sir. So I am here. Dr. Poonam is here. Because this is a morning time today, many of the moderators were not available. But I have a question here. You have covered cancer, whatever, everything very well. How can we drive a point to the patient's mind that yes, treatment of obesity is actually prevention of cancer? It is like trying to stop smoking or any carcinogen, but it's been a challenge.
You are right. Patients are not in mindset of accepting obesity as a cause of cancer. Leave aside type 2 diabetes, etc. Nowadays, it has come into focus that you can reverse diabetes, but you can reverse your chances of developing malignancy. Also, should be told to the patient. We need a lot of patient education. I'm listening since morning about diet and exercise. Exercise, I think we have not covered today. But these things patients don't listen to. Especially I'm worried because our patients don't even listen to putting on mask and keeping distances. If you see the rising rate of corona and the behavior of the patients, then it is difficult how we can convey this particular factor. Those simple things are also not understandable by them. Very poor state of patient education we have.
Very true, sir. So there was a point discussed, and I'm going to ask this question to you and also ask this to Dr. Unikrishnan, that the effect of vaccine is slightly blunted in morbidly obese people. So by evaluating their antibodies, would it be a wise suggestion to suggest the third booster dose, especially because they have more inflammation? It is difficult to use long needles, and I don't see long needles being used for vaccination for better penetration. So this is a thought, maybe something new can come out of this meta search. I'll be
I
more than
think
happy.
you're right. If we measure antibody levels regularly and if we find response is poor, then this should be recommended third booster dose or second booster, you can say. But it is must for people with BMI more than 35 at least, morbid obesity.
Thank you. Thank you so
Okay.
much, son. Thank you for your time. Good day. Dr. Hardik, Dr. Unni Krishnan is waiting. Yes. So Dr. Unni Krishnan, I know him for almost more than 18 years now. A very well-known endocrinologist, researcher. He's from South. Luckily now, Pune is blessed with his presence in Chelaram Hospital as a CEO. The leading diabetes institute in India, and his conferences are known worldwide. He has multiple publications, former editor-in-chief and founder, the Journal of Thyroid Research and Practice, executive director of Indian Journal of Endocrinology and Metabolism, more than 160 publications in Index Journal. My God. He has received the Subhash Mukherjee Oration Award of Endocrine Society of India, Srivastava Award of RSSDI. I'm sure there are many more. Jacob Memorial Prize for Best Patient Care awarded by Christian Medical College, Vellore in 1998. Fellowship Award of RSSDI in 2017. Sam G.P. Moses Oration by Diabetes Association of India. And he received the Diabetes Excellence Award at Digital Diabetes Summit, Hyderabad. And I know he's conducting a lot of research. And that is why I'm requesting to speak on GLP-1 array status, present status, and future. And he knows more about what is likely to come. Dr. Unni Krishnan, please.
Friends, it's a pleasure being here, and I thank Dr. Shashank Shah for inviting me to give this lecture on GLP-1 receptor agonists, present status and future. This will be my agenda for today's presentation. I'd like to begin by looking at GLP-1 receptor agonists and the promise of CVOT, obesity therapy, the advent of oral GLP-1 receptor agonists, and gazing into the crystal ball. We are all aware that GLP-1 receptor agonists increase insulin secretion, suppress glucagon, suppress appetite, cause weight loss, type 2 diabetes control, and also may protect against cardiovascular outcome trials. There are a lot of cardiovascular outcome trials which have now come out with GLP-1 receptor agonists, and there is one on dulaglutide, which is a weekly injection, liraglutide, which is a daily injection, and semaglutide, which is a weekly injection. So both dulaglutide and liraglutide resulted in a 12% and 13% reduction in MACE. What is MACE? MACE essentially refers to major adverse cardiovascular events, and which is a composite endpoint of non-fatal MI, non-fatal stroke, and cardiovascular death. So in both these studies, dulaglutide and liraglutide, there was a superiority compared to placebo in terms of CVOT, which shows that GLP-1 receptor agonists do not just control the blood glucose levels and help people lose weight, they also improve cardiovascular outcomes. But if you look at the semaglutide study, the study was powered for non-inferiority. Superiority versus placebo was not pre-specified. Nevertheless, there was a MACE reduction of 26% with weekly semaglutide. If you want to look at the REWIND study, which was done with dulaglutide, which is a once-weekly injection, you will find that dulaglutide significantly reduces the incidence of major adverse cardiovascular events by 12%. But if you were to look at the study very carefully, the major benefit was seen in non-fatal stroke, because you can see the upper limit of the confidence interval is well below 1. The CV death confidence intervals and the non-fatal MI confidence intervals both overlapped 1, and the all-cause mortality also overlapped 1, suggesting that this benefit of primary reduction of major adverse cardiovascular events was driven by a reduction in stroke. That brings us to semaglutide, which is a human GLP-1 analog. Semaglutide has a series of amino acids, as you can see, the spacer, which is linked to a C18 fatty acid chain. And this means that there is almost a 94% homology human GLP-1 and a T-half of approximately 1 week. So this can be given by once a week injection, and because of the binding to albumin, it is a very, very long-acting drug. Now, this is a cardiovascular outcome trial which was published with weekly semaglutide, showing you that the p-value was 0.02 for superiority, showing you that semaglutide reduced major adverse cardiovascular events driven by a reduction in non-fatal MI, some reduction in non-fatal stroke. Of course, the cardiovascular death wasn't significant. So I finished the first part of my presentation where I talk about GLP-1 receptor agonists, which not only control type 2 diabetes, not only help in reduction of weight, they also improve cardiovascular outcome. And there is some data on renal outcomes emerging as well. I want to talk about the oral GLP-1 receptor agonists. So far, GLP-1 receptor agonists were given by injections. Now we have the oral GLP-1 receptor agonists come. GLP-1 receptor agonists are peptides, and the challenges of giving a peptide orally are degradation in the stomach by the pH and the proteolytic enzymes, the limited permeability across the gastrointestinal epithelium, and of course the GLP-1 receptor agonists administered alone have very low bioavailability. To overcome that, we have a tablet oral semaglutide, which is coupled with a co-formulation with something called SNAC, which is sodium N8-2-hydroxybenzoyl aminocaprylate. Now, combining semaglutide with this absorption enhancer called SNAC is important to achieve adequate bioavailability. The SNAC is a very small fatty acids which promotes absorption across the gastrointestinal epithelium, and oral semaglutide is co-formulated with 300 mg of SNAC. Now, preclinical data have shown that oral absorption of semaglutide occurs in the stomach. You have the stomach here, the spleen here, the pancreas here, the portal vein here, and absorption, as you can see, occurs in the stomach. You can see this, the semaglutide concentration in the splenic vein here and the portal vein here and the time since administration, and you can see the values rising. And how to take oral semaglutide? Once you wake up fasting and take the semaglutide tablet with half a glass of water, wait for 30 minutes before eating, drinking, or taking any other oral medication, and then have your first meal and drink of the day and take other medication. So this is important to note when anybody is taking oral semaglutide. Food intake before the dosing will reduce the absorption. Increasing water volume is also a factor that is important, and decreased post-void dosing time. All these are factors that decrease semaglutide exposure. So this is the cardiovascular outcome data with oral semaglutide, the Pioneer 6 study, which showed that MACE reduction was 21%. The p-value was less than 0.001 for non-inferiority for cardiovascular outcomes. It did not meet superiority. So the drug nevertheless reduced some aspects. For example, oral semaglutide reduced cardiovascular death significantly. You can see the hazard ratio was 0.49, suggesting a 51% reduction in cardiovascular death, and the upper limit of the confidence interval was 0.92. Non-fatal MI and non-fatal stroke were not significantly reduced. All-cause mortality was also reduced in Pioneer 6 with oral semaglutide. Very notably, oral semaglutide actually reduced HbA1c significantly. As you can see, the dark blue color is oral semaglutide and the gray color is placebo. Oral semaglutide also helped in weight loss of up to 4.2 kilograms. So weight loss, improvement in diabetes. So to summarize, oral semaglutide has been shown to reduce HbA1c superiorly compared to empagliflozin and sitagliptin. It's non-inferior to liraglutide. weight loss of semaglutide is superior versus sitagliptin and liraglutide, similar to empagliflozin. Cardiovascular safety showed a 21%, but it was a non-significant reduction in MACE. And of course, oral semaglutide was well tolerated, and mild to moderate nausea was the only side effect. Efficacy was established when given early in therapy, late in therapy, and regardless of hepatic renal outcome. So that brings us to a very recent study of injection semaglutide. Injection semaglutide as compared to placebo on body weight. So this paper is published very recently. It studied 1961 adults with BMI of 30 or greater, or more than 27 with more than one weight-related coexisting condition. This study looked at people who did not have diabetes, randomized into 2:1 ratio of semaglutide once weekly. This was an injection, I want to highlight, 2.4 mg or placebo. And the co-primary endpoints were the percentage change in body weight and a weight reduction of 5%. So these results were recently published. And what these results showed is that there was a significant reduction of weight from baseline with semaglutide, almost a 15% reduction, almost in studies showed a 15 kg reduction in body weight. And if you see the trial data, 32% of patients on semaglutide lost more than 20% of their body weight. 50% lost more than 50% lost more than 15% of their body weight, and 86% lost more than 5% of their body weight. So good reduction, almost 15% weight reduction with semaglutide. And that brings us to what is the future of these drugs. My agenda was to look at cardiovascular outcomes, treatment of obesity, talk to you about GLP-1s and their effects, and then finally look at current and future drugs. So the future is of drugs which are the new generation GLP-1 receptor agonists and the dual and triple GLP-1 receptor agonists. And of course, you have newer agents for obesity, which are probably not part of my lecture, but amylin analogs, leptin analogs in combination, and of course, special GLP-1 and glucagon receptor agonists acting on the liver, GLP-1 and GIP receptor agonists. So if you look at GLP-1, GLP-1 will suppress glucagon, increase insulin, and help in weight loss. GIP is another hormone. But GIP can increase glucagon, but it is also increase insulin. It's also obesogenic. But in the right proportion, it can increase insulin, and maybe it can help to control diabetes just a little bit. But it has problems with glucagon increase and obesogenic. If you look at the third group of drug, which is glucagon, glucagon agonism can increase energy expenditure, but it can cause weight loss, but it is diabetogenic. But if you combine these cleverly, then you can harness their effects clinically. For example, you give these drugs at a particular combination. A combination of GLP-1 and GIP could be called twin cretin, and the combination of all three groups could be called triple cretins or incretins. GLP-1, you could harness it because it suppresses glucagon, increases insulin, and results in weight loss. GIP could be harnessed to increase insulin, but if you do not want weight loss, you would add it. You have lean type 2 diabetes. And glucagon, it can help in weight loss and energy expenditure, but it could be diabetogenic. So the future could see more and more of these peptides being combined. And of course, you have amylin analog antagonist, amylin agonist, you have pramlintide. So all these hormones could be combined in various proportions to give benefits such as diabetes control, increasing insulin, suppressing glucagon, increasing insulin more strongly, energy expenditure, weight loss. So all these effects could be seen by combining these triple peptides or then agonists or partial agonists in different ways. So friends, I have completed my presentation. I talked about GLP-1 receptor agonists and gave you an introduction to obesity and CVOT therapy. I talked about the effects of oral semaglutide. Then I talked about the very recently published, just a few days back, published step 1 study which looked at injection semaglutide in non-diabetic obesity and showed that it produces a 15% weight loss, very good weight loss in my opinion. And I talked about the promise of uh, twin cretins and triple peptides in various combinations to harness the metabolic syndrome, to control the blood glucose, increase the insulin, to suppress the glucagon, to cause weight-related benefits, and to also help in energy expenditure. Well, the future of obesity therapy with diet, exercise, therapeutic drugs, bariatric surgery, and exciting new molecules on the horizon. The treatment of obesity is very bright, and I hope that people with obesity are able to control their weight and prevent obesity-related comorbidities. It has been a pleasure discussing this topic with you, and thank you for listening to me.
Thank you, Dr. Anikrishnan. Excellent presentation as usual, and really one of the best overviews. I definitely feel from your presentation that the algorithm of obesity management would change, and pharmacotherapy in future will take more and more and better role, even without bariatric surgery, and I believe even after bariatric surgery. What do you think about these molecules being used to extend the long-term results of bariatric surgery? I'm asking you as a bariatric surgeon.
Sure, sir. So I do not feel that these molecules can, substitute for bariatric surgery. No, I think bariatric surgery is bariatric surgery, and the results are fantastic for anybody to see. What will happen is obesity may be a disease where these peptides are used to supplement the benefits of surgery. So before bariatric surgery, after bariatric surgery, these medicines will be used. Then for patients who are too sick or who refuse bariatric surgery, this will be a second best option. Though we should, in my opinion, wherever there is obesity requiring bariatric surgery, we must do our best to convince the patient. But if not, this could be a therapy. But no, I think bariatric surgery cannot be replaced by any exciting new drugs on the horizon, but it can supplement and add to the benefits.
Thank you. Thank you for the comment. We remember your famous paper published on medical reversal of diabetes.
Thank you, sir.
Do you think that this should be as a continuum after medical reversal of diabetes, this therapy, and any more follow-up on that paper?
So, yes, I think we've shown that type 2 diabetes can be reversed with weight loss and low-calorie diet. But in my view, this weight loss is not a true reversal of diabetes. It is just a temporary remission of diabetes. Because if you see Dr. Roy Taylor's paper at 2 years, a significant proportion of patients actually regain their weight back. So after an initial reduction, adding weight beneficial drugs such as SGLT2s and GLP-1s and metformin in the right proportion will keep that weight low and will maintain the person in some remission. Then, but then you are questioning a remission itself, because if you have to give tablets, it's not a true reversal. So in my opinion, it is a guided remission and it is not a true reversal that can happen. And that also holds good for all the special diets like keto, 2 times a day, time restricted diet, or vegan diets. All these diets can cause a temporary remission, but not a true reversal. And we need to look at these exciting molecules carefully in future.
Thank you so much. We just enjoyed an extensive meeting of yours last week, and in spite of being busy, you still found time and gave an excellent presentation. Thank you so much. Have a good day.
Thank you for the nice comments about me, sir. Thank you.
Thank you. Hardik, can we have the next presentation? Dr. Sunil Jain. Yes. So Dr. Jain is known as a medicopreneur. Thank you, Dr. Jain, for joining this. He is popular in medical field, particularly with those who are into the fields of diabetes, thyroid, hormonal imbalance. His book titled Madhumeha, Ek Naya Jeevan Sathi, released by Prime Minister Mr. Atal Bihari Vajpayee at Prime Minister's office. He's written this book long back and it's very well received even till today. Total was opened in 2010, where patient and doctor could take advantage of changing technology advancement and treatment by taking training. All over the country, about 2,000 doctors for diabetes and thyroid were imparted with modern training system for treatment by Dr. Jain. Dr. Jain is using this technology extensively to empower patients, and we are fortunate to have him in this meta search. May I request Dr. Hardik to have his presentation started, and our next speaker is Dr. Yogesh Kadam. He can also moderate or comment on these.
Going to talk on positioning of dapagliflozin as an integral part for the management of heart failure. And to begin with, let me discuss few case studies first. This is a 70-year-old male who is having hypertension, obesity, and diabetes since 18 years. Though he did not have any prior history of heart failure, but now this time presented with typical symptoms of heart failure like dyspnea on rest with pedal edema and RELS and elevated JVP. On investigation, he has an ejection fraction of 30% with elevated NT-proBNP level. He also has a CKD with the eGFR 50 and increased urinary albumin-creatinine ratio to 150. His diabetes is otherwise well controlled on insulin glargine, metformin, and sitagliptin. He is also receiving ACE inhibitor and beta blockers for hypertension. Now, this is a patient with type 2 diabetes, CKD, and heart failure. What should be our next line of management? Another case, a known case of HFrEF, 60 years age, CAD, hypertension, and he is non-diabetic. He was diagnosed to have HFrEF 2 years ago. And now he again comes with a worsening of symptoms of dyspnea on exertion while pedal edema. And historically, he had frequent hospitalization more than 5 times in last 2 years. Very high NT-proBNP level with ejection fraction of 25%. GFR 60 with increased UACR. He is on calcium channel blocker, beta blockers, ACE inhibitors were added 2 years ago because of HFrEF. Currently, though on a suboptimal dose with MRA, which were discontinued because of hyperkalemia issue, and he's on a standard care for acute coronary syndrome. So now this patient, what should we do for his heart failure management? And another case where HFrEF is there with a worsening of renal function. This is a 65-year male diagnosed with heart failure 3 years. And he has frequent heart failure hospitalization. He had CAD hypertension, but he is a non-diabetic. Now somebody with a CAD, hypertension, frequent heart failure, and already receiving so many medications, and here again, his mineralocorticoid receptor antagonists were discontinued because of hyperkalemia. And he comes again with deterioration of the symptoms of heart failure like dyspnea and pedal edema. Also has a high NT-proBNP level with an echo showing 35% of ejection fraction. And in a setting of a GFR of 38, obviously this cardio-renal connection is very strong in this patient. And his NT-proBNP level is increasing and his GFR has gone down in last 4 months. That means here the heart failure is worsening and CKD is also worsening. So what should be the next line of management for such a patient? So we know that these are the standard of care guidelines which were around 4 or 5 years ago, like patients with symptomatic HFrEF treat with beta blocker and then add on mineralocorticoid receptor antagonist, and if they are able to tolerate ACE inhibitor or ARB, consider those. If there is a no bradycardia, then consider evaporating, or if there is a sinus rhythm, etc., abnormality are going on with a prolonged QRS, then consider CRT, etc., etc. But nowadays things are changing, and that is what is the objective of discussion. And then came the ARNI era, where we saw the paradigm heart failure trial, which has shown that there was a 20% benefit with ARNI when it was compared to ACE inhibitor. And that's how the era for ARNI started. but we simultaneously can see that still, in spite of addition of ARNI, there is a big residual risk for heart failure remains. So what can we do additional? And here, the thing which has happened, that is after the era of SGLT2 inhibitors, we saw a big change in the management of not only diabetes, but other cardiac and renal disorders. And there we have now a new trial data for dapagliflozin on heart failure, particularly in with reduced ejection fraction. So let me talk on the DAPA heart failure study, where the dapagliflozin was used in patients of heart failure irrespective of their diabetes status. And this trial was done to test the hypothesis that SGLT2 inhibitors, they were found beneficial in heart failure with diabetes, but this benefit is not due to just glucose reduction. That means these drugs should be effective in heart failure without diabetes as well. And that's how this big trial of 4,744 patients was initiated. And only patients with known heart failure were included in this study with elevated NT-proBNP level with LV ejection fraction of less than 40% within last 12 months. eGFR was more than 30. Standard care was continued. And now we can see here that the dapagliflozin was given in the half of this population while remaining half received placebo. And the objective of the trial was to find out the composite endpoint of cardiovascular death, hospitalization due to heart failure, and worsening of heart failure requiring urgent visit with these remaining secondary endpoints. In this population, this is a very interesting data of this DAPA heart failure trial where the mean age of the patients was 66 years. The BMI average was 28 and a heterogeneous population with 23.5% were Asian with a GFR mean was 66. Though we had many patients with a eGFR around more than 30, so around 40, 45 like that. And interestingly, the mean NT-proBNP level median was more than 1400 with a mean ejection fraction 31%. And in this trial, we can see that around 11% patients were on ARNI, that is sacubitril valsartan drug as well. And now if we look at the results, and these are the various anti-diabetic management going on. So this is a trial where 45% patients were having heart failure with type 2 diabetes, while 55% participants had no type 2 diabetes, but they had heart failure, and I had already discussed the inclusion criteria. Ejection fraction less than 40% with a high pro-BNP level. And now what we saw, there was a significant reduction in composite endpoints, that is cardiovascular death or worsening of heart failure by 26%. Cardiovascular death was reduced by 18%, and hospitalization due to heart failure was reduced by 30%. So all values very significant. And the consistent benefit was seen across for hospitalization due to heart failure, all-cause mortality. There was a significant improvement in heart failure symptoms. So overall, this was a well-tolerated drug, proven to be very useful in patients who are having heart failure, irrespective of diabetes status. That is what we learned. And significantly reduced risk of CV death started from day 28. So when we start this therapy, around 1 month, we are going to see, from 1 month onwards, we are going to see a benefit. And here we can see that the benefit was irrespective of the glucose status, both normoglycemic, pre-diabetic, and type 2 diabetic. All the population had more or less same benefit. So dapagliflozin, in addition, reduced the incidence of new onset type 2 diabetes in that cohort which was having pre-diabetes, and this was expected. This was irrespective of eGFR status. We can see that the dapagliflozin had a benefit in patients with heart failure. That means in a combination of heart failure with, if the eGFR is in addition low, then this becomes a very good indication for a SGLT2 inhibitor like dapagliflozin. And we can see across all age, across all groups, we can see a good benefit of dapagliflozin in comparison to placebo. Here we can see the difference in the all groups. And this is the most interesting one, important area in this trial. Around 10% patients were on ARNI as well. And we can see here that 41 patients in the ARNI plus dapagliflozin had event, while 56% patients in ARNI without dapagliflozin. That means if dapagliflozin is added on the top of ARNI, the benefit are same with a hazard ratio of 0.75. That means this combination also can have an additional advantage. And these are the safety profile. Overall, dapagliflozin was reasonably safe. No big volume depletion kind of issues or renal adverse event, which were thought of very in the beginning when SGLT2 inhibitors were launched. And we can see here everything was reasonably good. So in general, dapagliflozin versus placebo, we did not saw any significant adverse effect profile. The urinary tract infection rate was slightly higher in the dapagliflozin group as compared to placebo. That is expected. These genital mycotic infections were relatively higher. This is another study on HFrEF, which is EMPA-REG, that is the EMPERA reduced versus dapagliflozin. And here we can see that there are differences among these two studies, and in fewer areas, dapagliflozin had shown a better response in DAPA-HF as compared to EMPERA reduced study. So what should be the positioning of dapagliflozin now as far as the heart failure is concerned? And we can see this is the 2020 heart failure ESC position paper, which suggests that dapagliflozin could be considered in the treatment of patients with HFrEF with and without type 2 diabetes. We know that the US FDA has already approved dapagliflozin for the treatment of heart failure irrespective of the diabetes status, and that is specifically for HFrEF. This is the Canadian Cardiovascular Society Guideline Update 2020, which again says for a recommendation of SGLT2 inhibitor such as dapagliflozin, because we have seen the data of DAPA heart failure study. So dapagliflozin, like SGLT2 inhibitor, should be considered in patients with ejection fraction less than 40%, because this has shown the benefit in terms of survival, reduced mortality, as well as reduced worsening or hospitalization of the heart failure. And that's how things are now changing from 2016, and we are seeing that there is a modification in the guideline. And now patients who are symptomatic with heart failure due to reduced ejection fraction, apart from ACE inhibitor, beta blocker, mineralocorticoid receptor agonists like conventional therapies, now SGLT2 inhibitors are coming right from beginning, and that's what are the recommendations. So SGLT2 inhibitor can be added at any stage, and this is a new learning, and that's how we can see that the big advantage of SGLT2 inhibitor as compared to other therapy for the heart failure is single dose, just a morning single dose, no dose titration needed, and many benefits, which is a very big topic. And that's how it's a very easy therapy to initiate for any patient. And that's how patient selection, then the dose selection, pre-initiation consideration, prescription, long-term, everywhere, dapagliflozin is too easy to manage. Just start with 10 milligram in all patients, provided the GFR is more than 30 in patient with HFrEF, irrespective of diabetes status, and some adjustment in the concomitant medications, particularly loop diuretics and the antihyperglycemic drugs can be done. And that's how the DAPA heart failure trial has now added one more pillar in the management of heart failure with reduced ejection fraction. And that's what we can see, and that's how now we can do the management of heart failure of our diabetic as well as non-diabetic patients in a better way. Thank you very much.
Thank you, sir. Very good presentation. I don't see Dr. Jain online, but I think he covered every part very extensively, almost no stones unturned. So hardly any question left. He explained it very well. Hardik, can we go to the next presentation, the last presentation for today, Dr. Yogesh Kadam? Yes. So we have Dr. Arun Kamar sir as the chairperson. Thank you, sir, for joining. And thank you, Dr. Yogesh Kadam, very experienced diabetologist, and we see thousands of his patients being treated and happy since 2004. He has treated more than 25,000 patients over the last 15 years. He has launched Pune Diabetes Center in 2006, which provides structured diabetes care. It's a large clinic located in the heart of the city. He is also involved in clinical research for diabetes, serves as an honorary associate professor of medicine at BJ Medical College, recognized as a teacher in medicine for undergraduate as well as postgraduate courses by Maharashtra University Health Sciences, MUHS, been a part of many prestigious clinical research projects involving diabetes and related products. Of course, he received reputed ICH GCP training from Brookwood International Academy, UK, FDA readiness training from Harrison Clinical Research, a reputed German research organization. So, thank you, Dr. Kadam, for joining us. Let us start his presentation.
Oh, Dr. Jain.
Oh, Dr. Jain, sir.
Yeah, good afternoon.
Thank you so much for joining. Hardik, just give
Yeah,
us a...
sorry. I just skipped it. So anyway, I just got a call.
Very good presentation. You covered almost everything.
Yeah.
I have one question. All these change in guidelines and whatever evidence we have, how have cardiologists changed their prescriptions after knowing these studies?
I think the prescriptions have changed quite significantly in cardiology practice also. And we are seeing that a good number of patients are receiving SGLT2 inhibitor from cardiologists. But what I have observed it is more often they are using this drug still in diabetes with heart failure and not in non-diabetic heart failure. The reason I feel that there may be some limitations in convincing the patient for using a drug which is primarily indicated for diabetes to be used in non-diabetic population kind of thing. But since this is quite a new thing, so I think that over a period of years, this class of drug will become the part of management of heart failure due to any etiology.
Thank you, sir. Thank you for sparing your time and joining us.
Thank you. Thank you. Thank you.
So I will take you to the next. Dapagliflozin, conquering new frontiers in DKD prevention therapy. This group of drugs entered the Indian market more than 5 years back. It came in as anti-diabetic drugs with good metabolic advantages like weight loss and reduction of blood pressure as well. Good A1C reduction and can be combined with any group of drugs because it is an insulin independent action. So you can combine with oral drugs, you can combine with insulin, beautiful anti-diabetic drugs with added benefits of weight loss and BP benefit. So really, as far as diabetes is concerned, these drugs in the first couple of years when they entered the market, they changed the scenario where diabetes could be managed in addition to weight loss. This was something really very important because we did not have effective weight loss therapies before. So this was an advantage the patients got in addition to sugar control, the good weight loss as well with the SGLT inhibitors, especially dapagliflozin. Let's start with this patient of ours. He is a prototype patient. This is only for educational purpose. He is having a worsening kidney function. He's 55 years old, diabetes 5 years, on anti-diabetic drugs. It's a triple combination of SE, MET, and EPP4 inhibitor at full doses. He's got hypertension, dyslipidemia, so basically typical metabolic syndrome. He's not yet got a CV event or heart failure. He's taking standard hypertension and lipid lowering drugs. So it's a high intensity statin, which is indicated for all patients of diabetes by most world authorities, whether it is the ESC or whether it is the AHA. They really recommend very high intensity statins for patients with type 2 diabetes. Already on ACE inhibitor, CCB as per guidelines. So he's on basic background therapy for hypertension and standard background therapy for hypertension and for dyslipidemia. Is on triple drug anti-diabetic therapy. His A1C is not bad. If you see his A1C is not very bad. His A1C is not very bad. It's just about 6.8. However, see his GFR. 6 mm. So he's already got into stage 2 CKD, and his USCR is 800. So that's really macroalbuminuria. You know, 0 to 30 is normal, 30 to 300 is microalbuminuria, and 800 is macroalbuminuria, almost reaching a gram of albuminuria. So he typically has diabetes only. He's done 55 years of age, has diabetes only for 5 years, along with comorbidities, hypertension, dyslipidemia, already on good background therapy. A1C not bad, but look at his GFR, which should be at least over 90 for his age of 55. He's already dropped to about 66, and his albuminuria is huge. So really, this patient is a really very high risk for kidney progression, also for cardiovascular disease. Since his last 8 months visit, he's gained about 2 kgs weight. His GFR is dropped by about 5 ml. So, and his USR is gone up by 20%. So he's progressing. See, the rate of fall of GFR by age is about 1 ml per minute per year. Here he's dropping about 5. So that's really, and this is very, very, a very difficult thing in India. The rate of progression of CKD in India is much higher than what is seen in the Western population. In Western population, people would progress by about 2 to 4 ml per minute worsening of GFR every year. In India, we are seeing our patients get down by 5 to 10 ml per minute per year. That's really bad, because you see, if it gets down by 5 ml, even if you say this conservative figure of 5 ml per minute, in the next 10 years, he's going to go on dialysis. He's at 66 per minute. In 10 years, he comes to ESRD, CKD stage 5, less than 15 GFR, and he would typically require dialysis. So something really urgently needs to be done in this gentleman. Is high renal risk, high cardiovascular risk. We are going to see that a little while from now. And we need to really stop his decline, halt his declining his GFR. The rate of decline of GFR really needs to be reduced in this particular patient, so that he doesn't get into dialysis in the next 10 years. So that is typically what we are looking at. How can we do that? Fortunately, we have agents now which have shown phenomenal evidence for doing what this patient would be required. Right. So when you basically diagnose CKD, you have the 2 classifications: the A on the x-axis and the y-axis. You are seeing the stage of the kidney CKD. So basically G1, GFR more than 90, then mild CKD. Our patient has typically 66 GFR, gets into G2, and then however, if it drops 5 ml per minute, is going to drop in the next couple of years to stage 3A, or the next few years to stage 3B, and is going to progress to CKD stage 5, G5, and that would require your indication for getting into dialysis. So typically our patients is over here, and this albuminuria is then again classified as A1, which is normal to normal albuminuria, microalbuminuria, and macroalbuminuria. The patient is here. So if you just chart our patient on both axes, and he is right over here, he's on A3 G2. So this patient is A3 G2. Also, we need to see his etiology. So clearly, he seems to be having a diabetic kidney disease. Of course, one needs to rule out non-diabetic kidney disease in all patients, especially when proteinuria is not very large, and if retina is normal. Those are the indicators that it may be a non-diabetic kidney disease. So we really need to rule out other causes as well. However, diabetic kidney disease, more than 50% of patients on dialysis in our country, for that matter in every part of the world, the etiology of the CKD is diabetes. So clearly, other differential diagnoses have to be kept in mind. The diabetes is the forerunner, is the front runner actually. So this patient has G2A3 CKD and would progress over the years to from G2 to G5, and was already in A3 that would get severe, and you typically end up with G5 and with dialysis in the next 10 years if intervention is not done. If an immediate intervention and an urgent intervention, an effective intervention is not done to halt him from progressing further down the track. Right. So this is what we are seeing again. As you go from the top, the G1 to G2, and from A1 to A3, the risk increases. And what risk increases? It's not just the risk of end-stage kidney and progressive kidney disease. There's also the CV mortality and all-cause mortality. Albuminuria is a marker of endothelial dysfunction. Albuminuria is a marker of cardiovascular risk. Patient is huge cardiovascular risk. In fact, most of our patients who present like this will probably die of a cardiovascular disease before they get into dialysis. So it's very important to address this cardiorenal risk for this patient, the progressive CKD, reduce the all-cause mortality, CV mortality, halt the progression of CKD, not let him get into ESRD. He's 55 years of age. We need to keep his kidney functioning at least for the next 20 years, if not more. So really, he's over here now, A3 and G2. This is where he is. He's a moderate risk patient now, and he would soon go with higher proteinuria and with the reducing GFR, couple of years he'll be here. And then of course he would just progressing downhill. So can we stop him from falling downhill? Can we stop his kidney disease from worsening? Can we stop him from getting into dialysis for at least for the next 20-25 years? And do we have interventions and evidence for those interventions? And fortunately, yes, we have a lot of these interventions and evidence for this intervention, which we are going to see further. So what is the unmet need for CKD management over a long time? This has been very intriguing. For the last 20 years, nothing major has come up. Nothing major has come up. See, the burden of kidney disease is huge. The prevalence is substantial and serious implications for costs and outcomes of healthcare. So if you see the figures globally, 1 out of 10 people get CKD, 2.6 million receive renal replacement, 1.2 million deaths annually, and the number of renal replacement is to increase by 5 million by 2030, and it's driven by aging, increase in hypertension and diabetes. These are the two worst, and a combination of these two especially is the worst combination for the kidney. Uncontrolled diabetes, hypertension, add to it smoking, and that becomes a really deadly combination for the cardiorenal axis, especially the kidney, what we are seeing over here. And almost developed nations, they spend 2 to 3% of their annual healthcare budget on ESK. And this is actually twice the cost of ESK treatment. So basically, this is a huge burden in terms of cost, in terms of morbidity, in terms of mortality. And if you see the distribution, a large part of that is actually driven by diabetes. The purple thing over here, and the age group, if you see, you are getting it across the age, especially in the younger ages in our country. And diabetes is the front runner, is the main culprit, which is running this epidemic of diabetes, and of course of complications of diabetes like nephropathy and CKD. Right. And the CKD mortality has come down. If you see over the years, this is from 2007 to 17, ischemic heart disease has come down by 9.7%. Of course, data from the West. Stroke has come down by 13.6%. COPD has come down by 13.6%. Look at the kidney disease, it's gone up by 1.5. So that's really the mortality has gone up by 1.5 over here as compared to the other diseases like ischemic heart disease, strokes, and COPD have come down. And then see the number of patients doing RRT. This is from 2010 to 2020. You see across the spectrum, if you see the Oceania and Africa and Latin America, and Europe and North America, it's steadily progressing. But look at Asia, where we fall. It's really going up quite high. The number of patients RRT in million is already almost 1.5 million in the Asian population as compared to the Western population. Also, there is a trend to go up, especially also in the North American population. But look at in the Asian population, progression is much faster and worsening is much faster with patients, lot of patients receiving renal replacement therapy. So it's clearly the burden of the disease is huge. The progression is rapid in our country, Asia, and our country especially. Progression, as I told you, that fall in the GFR can be very rapid. Patient can progress from a GFR of 40 to 12 to less than 20 and less than 15, that is stage 5 CKD. Over a period of couple of years, we have seen patients falling downhill and requiring dialysis in a short time. If NSAIDs are the insult which may be responsible, the non-proven therapies, Ayurvedic stuff is also maybe implicated. Patients' compliance with treatment and with monitoring and lifestyle is also again a very important factor. Patients usually want shortcuts and get into all these things, actually land up in big trouble. So clearly the progression is faster. Patients receiving RRT is huge in the Asian subcontinent. Right. Now, this is what was found from 1997 to 2013, and some of them have seen the market, and some of them have not. You have seen Ramipril was the first HOPE study, Micro HOPE. Professor Salim Yusuf, way back 1997, huge study. The HOPE set the stage for large studies in the era of medicine and diabetes in particular, clearly showing that the progression of CKD can be halted by Ramipril. Then came the ARBs. Evidence was not initially with ARBs, so one was not sure whether they do as good as Ramipril. Of course, Irbesartan had evidence with an identical study. Losartan with the renal and Olmesartan with the roadmap clearly showing in proteinuric patients with CKD, you can get reduction of progression of CKD. And so these were the drugs which were standard, which are now established as standard of care for a very long time, that these drugs can halt the progression of kidney disease. There's a compelling indication to use these drugs with hypertension or albuminuria or a combination of both to halt the progression of kidney disease. So these ARBs have the evidence, the ACE inhibitors have the evidence. However, after that, a combo was used, and the combo was shown to have a lot of hyperkalemia, a lot of adverse effects, and the studies were stopped prematurely, and then combos actually are contraindicated now for CKD. Then came the renin inhibitor, L-carnitine again went off the market because it did not show good effects. Sulodexide was tried, and that also failed to show any benefits. And then you have the bardoxolone methyl, which was tried. So all these therapies after 2011, and many more are not shown over here actually. So whether it's a combo of ACE inhibitor ARB or renin inhibitor or the other experimental drugs, a lot of them were tried. None of them saw the light of the day because they either had too many adverse effects or they were not very good on the efficacy part of it. So we are stuck up at 2011. After 2011, we have not had meaningful progress, almost a decade now, any meaningful progress or any new additions to this standard of therapy. It can halt the progressive drop in kidney function, namely the GFR. Right, and that is how SGLT2 actually have come to our rescue. We can say these drugs have really added life to patients of diabetes with kidney disease. The evidence is far more reaching than even the ACE inhibitor ARB data. Dedicated studies for dapagliflozin are available, the DAPA-CKD study, which we are going to also touch upon. And the CVOT outcome studies of SGLT2 inhibitors showed good renal benefits. Dedicated studies available with dapagliflozin and canagliflozin have shown made very good benefits for this group of drugs as far as the kidney is concerned. And there may be a lot of. So basically, one has to understand that this anti-diabetic effect of the drug is dependent on GFR. So basically, for a good anti-diabetic effect, weight loss, and A1C control, you require a good GFR of about 60. You get good benefits. Up to 45, you get modest benefits. And really after that, you don't get any much anti-diabetic effect. Below 30, you would not get any meaningful A1C reduction. However, the cardiorenal benefits of these drugs, namely heart failure, the pump and the filter, the kidney, the pump and the filter, this group of drugs in general and dapagliflozin in particular, which has now a dedicated heart failure study, pump failure study, the DAPA-HF study, which is published, huge immense benefit in diabetes as well as non-diabetes population. The DAPA-CKD study with kidney with really lower kidney function, showing again good benefits in the diabetic and even non-diabetic populations. One has to understand that these drugs, these benefits to the heart and kidney are different from the anti-diabetic effect of the drugs, which really does not depend on the GFR. This cardiorenal benefits, and we are truly talking basically of the renal benefits, are seen even with GFR below 45. In fact, the latest KDIGO guidelines say that you can continue the drug, you can start the drug above 45. You can continue it up to 30, and you can continue it to up to dialysis. Do not start below 30. They say do not start below 30. If your patient is already on the drug, for the renal benefits, you can continue the drug till the end point of dialysis. And this data has come from the DAPA-CKD study. The DAPA-CKD study had enrolled patients with the GFR as low as 25. I was fortunate to be a part of the study as an investigator, and the study went on for more than 2 years, more than 4,000 patients across the world, diabetes as well as non-diabetic population, and really showing overwhelming benefits. The Credence study was published about a couple of years back, which showed good benefits with canagliflozin. It was thrilling at that point of time. The results were much better than the ACE inhibitor ARB benefit data. So it was, the word used for the Credence study data was overwhelming benefits. So huge benefits seen for reducing the progression of CKD and loss of GFR. Now, the results of dapagliflozin when they came, they were unforeseen. The word used is unforeseen. So for the Credence, it was overwhelming, and for the DAPA-CKD studies, it is unforeseen. That means better than the overwhelming. Huge benefits, all-cause mortality coming down, endpoint of doubling of serum creatinine, dialysis, renal replacement therapy. Huge benefits. The study had to be called off prematurely because of phenomenal benefits in the dapagliflozin patients. So the data is absolutely so positive that I would go and say it's a crime not to give this drug to a patient of CKD, whether diabetic or non-diabetic, to stop the progression of kidney function. Because as you have seen, after 2011, there has not been anything really major. So these drugs are actually elixir for patients with CKD to stop the progressive decline of kidney function. And there could be multiple mechanisms which are involved. And the main mechanism, which is thought to be the most important mechanism, is tubulo-glomerular feedback restoration. So the TGF. So basically, you have the afferent arteriole and the efferent arterioles, and then there is glomerular hyperfiltration and increased glomerular pressure. The glomerular hypertension is the main feature of diabetic kidney disease, which causes proteinuria and declining kidney function. And the SGLT2 inhibitors, because of this reabsorption of glucose over here, changes the tone of the afferent arteriole. It gets restores the glomerular pressure, reduces the glomerular pressure, and therefore that seems to be the main mechanism. So basically, what happens is because there is a blocking of the sodium and glucose reabsorption over here, it goes down. There is glycosuria because of the SGLT. Normally, SGLT2 would bring it back, would reabsorb all the glucose. Block this with an inhibitor. This all glycosuria goes down, and sodium reabsorption also goes down. Sodium and glucose reabsorption is stopped. So therefore, less sodium reaches the macula densa. Less sodium reaches the macula densa. That gets the tone of the afferent arteriole to normal, and that reduces the intraglomerular pressure. That reduces the proteinuria. So that seems to be the major mechanism. There could be other ones like pro-inflammatory pathway activation, is reduced, direct tubular toxicity is reduced. There is improved cardiac function, hematocrit, increased oxygen delivery to the kidney, improvement in renal hypoxia. So these are 4 or 5 major mechanisms which the slide has highlighted, which may be the reason, which is the mechanism of action for the kidney benefit with this drug. And if you see this cardiovascular outcome studies, you see the kidney outcome study with canagliflozin. You had 4,000 plus patients, but you see the number of patients with a GFR less than 60 were about 60% patients had a GFR less than 60. So really low GFR patients over here. Mean GFR of this study was 56.2. This is a dedicated renal outcome study, primary renal outcome study, for huge benefits as I have told you. EMPA-REG was a CV outcome study. There were only about, say, 25% patients, more than 25% patients with a GFR less than 60. Others had fairly good GFR. Canvas again had a large number of patients with good GFR above 60, only about 20% with GFR below 60. Yeah. Declare TB was a predominantly primary prevention cohort with only about 8% patients having a GFR less than 60. So these are different cohorts. You cannot compare head to head, but look at the cohorts, the differences. Whereas this is a kidney outcome study with a large number of patients, almost 60% with GFR less than 60. You see the mean GFR of patients of EMPA-REG and of Canvas and of declared TB. So this is the lowest, and of course it goes on progressively going up. Declared TB had the less sick patients as kidneys concerned, and even with that, all these across this spectrum of CV outcome studies, where actually the patients with stage 3 CKD were actually very low. Benefits were seen for the kidney in terms of endpoints of dialysis, renal replacement, 50% drop in GFR. And this, of course, was the one which established that even in patients with a low GFR, you get huge renal benefits with the canagliflozin, the Credence study. So across the spectrum, the renal benefits. Similarly, for heart failure, across the spectrum, the heart benefits are seen with all of these drugs. Right, so this is declared TB. This is a renal composite endpoint, and renal composite endpoint was 40% decrease in GFR less than 60, ESRD, dialysis for more than 90 days, kidney transplantation, GFR less than 15, renal or CV death, very hard outcomes, pre-specified outcomes, secondary outcomes in the declared TB. Remember, declared TB is a primarily CV outcome study. Secondary is pre-specified kidney outcomes. You are seeing a 24% reduction in the composite endpoint of kidney. So really huge benefits. And even with the population whose GFR is about 85, so very healthy GFR, and my albuminuric patient is only about 30%. So only 30% patients with albuminuria. That means the remaining 70% have normal albuminuria. So very early in the kidney disease, still you are seeing these very nice benefits in the declared TB study. So renal benefits have been phenomenal with this group of drugs, especially with dapagliflozin, and in the population which matches to what patients we see in our day-to-day practice. Remember, the Canvas has 6 patients. Only about, say, 1 or 2 out of 10 patients would be a EMPA-REG or Canvas or Credence type patients. The remaining 7-8 patients are healthy patients with fairly normal GFR, and the evidence is only with dapagliflozin for these patients for halting the progression of kidney disease by 24% in the composite endpoint. Again, renal specific outcome, you are removing solely GFR more than 40%, ESR renal death. Again, you are seeing a huge 47% benefit, 47% benefit for renal outcomes. So that is data is overwhelming. It is overwhelming. That's why I said if you are not giving this drug for a patient with CKD and if there are no contraindications, then I think it's you're not doing the right thing. It's not doing justice. And this particular benefit was seen across the eGFR groups and with patients with or without established cardiovascular disease. So say the baseline GFR more than 90, 60 to 90 or less than 60, all across you are seeing good benefits. Overall population is over here. We're getting good benefits with dapagliflozin in the primary composite renal outcome. And again, the primary composite renal outcome in patients, overall populations, with established disease or without established disease. 60% patients of the declared clinical study were patients with multiple risk factors without established cardiovascular disease. 40% had established cardiovascular disease. Both the groups, you are seeing very good renal outcomes, irrespective of whether the patient has established cardiovascular disease or no, irrespective of what GFR is throughout the spectrum. So a large variety of your patients, a large group of your patients are going to benefit from this drug for the renal outcomes, which is what it is. The application of the drug is to a large population. Right. Now, across the baseline CV risk and eGFR categories, whether patient had established disease or CV disease or only risk factors, whether he had heart failure or no at baseline, whether he had hypertension no at baseline, whether his GFR was what. We have seen some of this data in the previous slide. Across the spectrum, you are seeing huge benefits for dapagliflozin over here. So, as I told you, large number of patients, whether they have established CVD or no, whether they have heart failure or no, whether they have hypertension or no, whether they are falling in which GFR category of GFR, across the spectrum, dapagliflozin is giving you positive renal benefits. Now, across the UACR, we have seen the previous data across UACR, HbA1c, and medicine categories. So it doesn't depend what their normoalbuminuria or microalbuminuria or macroalbuminuria. Doesn't depend whether they are less than 7, 7 to 8, 8 to 9, or more than 9. Doesn't matter if you are an ACE inhibitor or ARB or no, whether a diuretic or no. Across the spectrum, again, you are seeing benefits across the spectrum. So irrespective of the baseline GFR, the albuminuria, the use of ACE inhibitor, ARB, that's really important because a lot of our patients get hyperkalemia with these drugs, and one has to withdraw these drugs for hyperkalemia. So even in those patients who are not in this hyperkalemia or with ACE inhibitor, you get with the drugs you get added benefit. Even without the drugs, you get benefit. So those patients really benefit if you give dapagliflozin for kidney protection. Right. And credence, compared with the credence population, even in patients with more advanced CKD, as I told you, this is an outcome for the kidney from the credence study. You're getting primary outcome, composite outcome, each component of the composite outcome, renal death, CV death, and if you see except CV death, all other components are significant, and except for renal death and CV death. I think the composite is positive, ESKD is positive, renal death, renal outcomes are positive, and then so these are the 1, 2, and 3. 3, 4 are the outcomes. It's less than hazard ratio 1. So you're getting wonderful benefit with canagliflozin with in the credence study. We have patients with much lower GFRs across the spectrum, and composite each of the components of the composite renal outcome, which is doubling of serum creatinine, ESKD, or CV death, or composite of all them. All of this significantly value. So that was the study which set the ball rolling. These drugs are good for the kidney, and DAPA-CKD only confirmed that in a much bigger and better way. So what the guidelines have done? Have the guidelines with the various organizations changed after this evidence has come? Yes, this is the European Renal Association and the recommend switching to an SGLT2 inhibitor plus metformin when patients with CKD with type 2 diabetes, A1C of S or metformin plus other agents. So it is the effect on the kidney is independent of glycemia. So even if your patients are less than 7 A1C with other drugs, it is a compelling indication to shift them to an SGLT2 inhibitor because of these benefits in the credence study and in the DAPA-CKD. Of course, the DECLARE study was and the CANVAS and the empiric outcome were the first ones to set the ball rolling. But these dedicated studies have meant that in patients with T2Ds, DM, CKD, not at goal, that is the CKD is defined as a GFR less than 60, and microalbuminuria or macroalbuminuria even the GFR more than 60. So the patient not at goal, definitely SGLT2 inhibitor. If it's still at goal, SGLT2 is not, but not SGLT2 is not tolerated or controlled, then use a GLP therapy. But here, even if your patient is on less than 7, it is a compelling indication to switch from the other agent to SGLT2 inhibitor and use GLP if your SGLT is not tolerated. So, but both the drugs have evidence for kidney, the GLP as well as SGLT2, but the GLP evidence is much lower, lesser as compared to the SGLT2. Injectable drugs, the GLP cost is a huge issue. Injectable is an issue. Oral drug dapagliflozin really can be used for kidney protection, even with the baseline A1C less than 7%. So that is how the guidelines have changed. This is how the guidelines have changed. The European Dialysis and Transplant Association and the European Renal Association. So this is ASN. This is American Society of Nephrology. And again, here they're saying if your patient has DKD, diabetic kidney disease, macroalbuminuria, SGLT2 inhibitor. The GFR is more than 30, SGLT2 less than 30, maybe a GLP receptor. High risk of HHF, SGLT2 inhibitor. Cardiovascular risk, either one of them. So for MACE benefits, you can use either of them. For heart failure and for the renal benefits, SGLT2 inhibitors are the one which has massive benefits for heart failure, pump failure and the filter, pump and the filter. For the pipes, the atherosclerosis, either one of them have inhibitors. But as far as the pump and the filter, the main evidence is with the SGLT2 inhibitor. That is preferred over the GLP-1. So you can risk the score for heart failure, and the score you just add up the points. The score is more than equal to 2. Then SGLT2, high risk of heart failure. SGLT2 inhibitor becomes the drug of choice over and above the GLP-1 agonist. So clearly for heart failure, clearly for renal disease progression, we've seen the data in the previous slides. Huge benefit with dapagliflozin to halt the progression of kidney disease. And this is what the KDIGO says, and that's really very interesting. So patients with diabetes, KD, of course, lifestyle intervention, and of course metformin. If your GFR comes below 45, reduced dose. If less than 30, you stop metformin for risk of lactic acidosis. Here, if the patient is on 30, do not start the SGLT, but you continue up to dialysis. That's really important. That's because the DAPA-CKD involved patient up to 25 GFR. And as investigators being a part of the study, we were encouraged to continue the drug for the patient till the patient reached the end point of dialysis, which we did. And therefore, this KDIGO has given this recommendation algorithm that you can continue it up to dialysis. And additional drug if required, and of course, we have the GLP-1 or the DPP-4 or of course the insulin, other anti-diabetic drugs. But clearly, patients with CKD, now SGLT2 inhibitor like dapagliflozin is what the KDIGO strongly advises, and continue up to dialysis. That's again a very bold recommendation in the algorithm. So I think we have come to the end of that presentation for dapagliflozin and kidney disease. And I thank the organizers for this opportunity for this talk. And that is it from my side.
Thank you, Dr. Kadam. Seeing you here after a long time. Very good presentation. May I request Dr. Arun Kamble sir to have his comments or question? Is he here? Anyway, how are you doing? All safe?
Yeah, doing fine.
Fine.
Doing fine.
I think you covered it very extensively. Almost no point was left from discussion. And a very good message given to everyone on DAPA and CKD. Thank you so much. I look forward to seeing you.
Welcome, definitely.
And have a good night.
Bye.
So we meet tomorrow at 4 p.m.
4 p.m.
Right.
More interesting topics and
Yes.
more interesting.
Tomorrow we have more interesting presentations, and we have some interesting talks from Dr. Ralph DiFranzo from US, Dr. Arya Sharma from Canada, who wrote the Canadian Obesity Guidelines. Have a good day. Look forward to seeing you all of you again tomorrow at 4 p.m. in the afternoon.
Bye.
Thank you.
Thank you.